This conference will now be recorded.
Hello, good evening all, and thank you all of you to attend today. And really, I'm very happy to be for the second turn in the crash course. I hope my session today it will be helpful for all. I try to make it as simple as I can, because you know these days you cannot enter in your any idea to be entered too much. No, you cannot. So better to just I will give you the important thing. Okay. The second thing, I think better not to talk with if you have any question, okay, or any query, just ask me in private, okay, in the Telegram, because you know I know your time is very limited now, okay. Because the second that this is our problem the last crash course, because a lot of people they are asking and no time, okay. Today inshallah we will discuss the vulval condition, vulval cancer. I did actually the cervical cancer and the endometrial cancer, but I don't know, maybe there is no time to do it. I try to make it as fast as I can, okay. Is my voice is clear, all of you, for all of you?
Yeah.
Yes, ma'am, it's clear. We can hear you.
Yeah. The second thing, I want to thank also Dr. Ghada for giving us a chance to help all, and also for our colleague, the mentors, all of them. Because you know some of us, for example, for me, I work in a very busy hospital, and I did this, alhamdulillah, but really it is an effort, because you know if you have a busy hospital and you have a kids and these things all, it will be a little bit difficult for you, but alhamdulillah, I did it. What I want to tell you is that today, just I want to see you if you can continue to complete this session today, because as you know, it is five topics today. Okay, so it may be a little bit difficult for you, but I think better to finish it today. But if you want, hello, hello, anyone talking? As we know, when things get hard, there is a success near about you. So don't get angry, and that you have a lot of things you don't want to read now, and you become upset, and sometimes even disappointed, because a lot of things you need to revise it. Okay, so when you feel that this all things, and it is what I want to tell you is that it is normal thing that you feel that all things now, and all things you didn't remember anything. This is normally. Don't be upset for that. If you enter the exam, inshallah, all the information will come to you, okay. But just I want to tell you is that this is a time to revise all the things that you read, okay. At least 7 guidelines you should revise it every day. This is very important at this day, okay, because you don't know as much as these days the brain will all things can download and can upload all things, okay, a lot of information at this time, not like before. Okay, this is normally, okay. So don't become upset, don't be disappointed, and also teams, if you have with you your study partner with you, also will help you. Try to revise anything you read. Don't neglect it, because you will need it in the exam, and you know this exam nothing will be withdrawn. Anything can come, okay. Really, it is a difficult exam, not an easy exam, the second part. So please, all of you, all things you read, revise it these days, okay. And in the 3 days or the last 4 days, you must read the gynae, the staging and the statistic, okay, even in the day before the exam, okay. I think let's start. Inshallah, don't stop trying. Success is very near. And I know these times you upload your mind with many information, and all these things will come to you. Okay? So inshallah, all of you will get success. Inshallah, you will reach this level, inshallah, near. Okay? I hope all of you will clear for this exam soon, inshallah. So let's start with the nice guideline of the vulval condition 2014. Okay? I hope my voice is... Hello? Hello? Is my voice is clear?
Yes.
Yes, I want to double check because we are...
Yes.
Yeah. So, this is the nice guideline. For the vulval condition, it may present to the genitourinary medicine physician, dermatologist, and gynecologist, and treatment modalities also span across this spectrum. What I did, I just make, because some information, it can come in the recall especially, and all of them, they are from also the previous guideline. So I try to manage the most important thing in both guidelines, the new and the old one, okay? So the vulval condition, as I said, may present to GM clinic, to the dermatologist and to the gynecologist. Treatment modalities also span across this spectrum, okay? Yeah, it is recorded, okay? Care of the patient with vulval condition is therefore best managed by MDT, as we know, which is a group of doctors, including all these those people, dermatologists and gynecologists, and this includes clear working arrangement between disciplines or access to a specialist multidisciplinary vulval service, and the service should also be access to clinical pathological discussion and review of the histology result. Okay, what about the history? In the history, what you will find in the vulval condition, most likely the standard gynae history will be done, will not identify all the relevant symptoms, sometimes because maybe there is a red flag for other hidden agenda, okay? So maybe cancer or maybe something, any sinister, which is hidden, okay? So history need to explore symptoms. No voice? Hello?
Clear, ma'am.
My voice is clear?
Yes, ma'am.
Yes, ma'am.
Okay. So please,
It's
the other
clear,
check your net. Yeah, please, other check your net. Okay. So standard gynae history, as we said, will not identify all the relevant symptoms, and history need to explore symptoms at other skin site, and medical history, drug history, and family history. Okay. Pruritus and pain, for example, non-specific other causes include vulval dermatitis. This is most likely to be come with this pruritus and pain, like vulval dermatitis, infection, contact dermatitis, hormonal deficiency, systematic skin disorder, and self-medication. All this can come with pruritus and pain. Past history of abnormal cervical smear is very important because related to the VIN and CIN, okay, very important. When you take history from the mother, you should ask also about if she had any abnormal cervical smear before. Regarding the cigarette smoking, immunodeficiency, VIN, contact with allergen, irritant, and detail of any personal or family history of autoimmune condition, because sometimes it can be linked with an autoimmune disease, okay, because it's an autoimmune also. So increased risk of Lichen sclerosis and even the erosive Lichen planus, okay. Circulating antibody are more frequent in women with erosive Lichen planus. In women with Lichen sclerosis, most common conditions are thyroid disease, alopecia areata, pernicious anemia, type 1 diabetes, mellitus, and vitiligo. And this is also, it can be 30% reported in first degree relative, which is, this is an SBA question. It can come in the exam. It even come in the previous recall. So if he said to you the percentage of that of patient with Lichen sclerosis to have a first degree relative with this, it is 30%. Okay. So you must know. Please, my voice is clear?
Yes, ma'am.
Yes,
Yes,
ma'am.
it's
Yes, ma'am. Clear.
Yeah, because others asking about my voice. Okay,
Yes.
this I want to confirm. So this is very important, and in the exam question, you should know from this. Yani, for example, in case of Lichen sclerosis, the patient can have a thyroid disease. She can have, for example, pernicious anemia. She can have type 1 diabetes. All these things, it can happen, and it can written in the scenario. Okay. History should include any personal family history of atopic condition, for example, hay fever, asthma, and eczema. And this is 97% had a history of atopic and or seborrheic dermatitis, which is also this is SBA. Also, it can come in the exam. Okay. Any history of urinary or fecal incontinence, allergy to sanitary products are rare, but many exacerbated by moisture, temperature, and friction. So even in the history, you should know about this because it may be a cause for this vulval condition. Okay, because it can have like irritation. Please, other mute. قصدك المؤشر كده يعني؟ دكتور محمد, I didn't understand you. Hello? Dr. Muhammad, what you asking? Because sometimes they tell me that the highlighter is not good for them. You see? So a minute. Sorry. Make laser better. Okay, so examination for the patient with vulval condition, it will include any anogenital region and other skin and mucosal site. Okay, adequate light and exposure, examination couch, modify licetum position, colposcopy is not necessary. Unless the patient have any abnormal smear, you should do for her colposcopy. Ask the woman to identify the symptomatic area if suspected VIN. For example, important to examine other lower genital tract sites, including vagina, cervix, and perineal skin. For sign of Lichen planus, important to examine the rest of the body, including mouth. For psoriasis, scalp, elbow, knee, and nail. This is very important in case of psoriasis. And even in the question, you can find that there is a skin manifestation in the scalp, elbow, knees, and nail. Okay. Eczema also may be seen at any site. General advice for all vulval condition: avoid contact with soap, shampoo, and bubble bath. This is one of SBA question. Okay, this is bubble bath. It should be avoided, which come in the exam. Simple emollient can be used as a soap substitute and general moisturizer. Avoid tight-fitting garment, which may irritate the area. Avoid use of spermicidally lubricated condom. Patients should be given a detailed explanation of their condition, with particular emphasis on any long-term implication for the health of themselves and their partner. Okay, this is very important. The patient's GP should be informed. STI screening should be considered in all. Patient and vulvovaginal candidates exclude if the patient present with vulval itching. All patients should be assessed for sexual transmitted infection or sexual dysfunction. Sexual partner tracing is not required unless screening detects STI. Okay. So Lichen sclerosis, and no exam without Lichen sclerosis, as we know. It is an inflammatory dermatitis of unknown etiology. Okay, its autoimmune factor may be involved in its pathogenesis, and recent evidence has shown autoantibody to extracellular matrix protein 14. And there is an increased frequency of other autoimmune disorder in female with Lichen sclerosis. Regarding the symptoms, there is itching, soreness, dyspareunia if introital narrowing, urinary symptoms. Other symptoms like constipation can occur if there is perianal involvement. So take care, all these things should be in your mind. It is autoimmune, okay? And it is there is autoantibody to extracellular matrix protein 14. Very important, okay? This is, you should revise this. this, because it can come to you in the exam. Okay? Is my voice is not clear?
It is clear.
Okay, fine. There is an increased frequency of other autoimmune disorder, as we said, in female with Lashen sclerosis. And as we said that there is itching, soreness, dyspareunia, urinary symptoms, and constipation if there is perianal involvement. So this is very important, okay? Even you can distinguish this from other condition, okay? This is the uncomplicated Lashen sclerosis as per strategy. What about the sign of Lashen sclerosis? There is pale white atrophic area affecting the vulva. Purpura, ecchymosis is common. Fissuring, erosion, but blistering is very rare. Hyperkeratosis can occur. Change may be localized or in figure of 8 distribution, including the perineal area. This sign, actually, this is that you should know it, because this is you can differentiate it from other conditions. For example, like fissuring, this is very important. For example, pale white atrophic area. For example, figure of 8. Okay, all these things, it can come in the scenario in the EMQ or in the SBA question. So you need to revise it well and to know that Lashen sclerosis have a figure of 8. Lashen sclerosis has a fissuring. Lashen sclerosis have a pale white atrophic area affecting the vulva. Okay, this is very important. Loss of architecture also may be manifest as loss of the labia minora and or the midline. This is complicated Lashen sclerosis. Regarding the complication, the development of squamous cell carcinoma, which is the actual risk is less than 5%. This is very important. That it can develop squamous cell cancer, the actual risk is less than 5%. Development of clitoral pseudocyst, sexual dysfunction, this is all complication of this condition. Okay. The diagnosis actually is a characteristic clinical appearance of histology of the vulval biopsy, thin epidermis with subepidermal hyalinization and deeper inflammatory infiltrate. In early disease, histology can be difficult. Okay? So in the diagnosis, it will be by histology, very important. Histology of the biopsy will show thin epidermis and subepidermal hyalinization and deeper inflammatory infiltrate. Okay? This is very, very important. For the management and partial investigation, when we take the biopsy in the case of Lashen sclerosis, if the diagnosis is uncertain, there are, for example, atypical feature or coexistent vulval VIN, okay? Or, for example, squamous cell carcinoma is suspected, okay? I think better to concentrate, my dears, better to concentrate, okay? For the investigation, for autoimmune disease, if clinically indicated, especially, for example, in case of thyroid dysfunction, T4 and TSH, so at that time, you can investigate for autoimmune disease, okay? For example, also for the investigation, you can do skin swab, only useful to exclude coexisting infection if there are symptoms or signs suggestive of this. Patch testing, which is rarely required and only if secondary medicament is allergy suspected, for example. So the advice of the dermatologist should be sought in this area, at this time, okay? So this is regarding the investigation. So as we said, autoimmune, if clinically indicated, skin swab, patch testing, the biopsy, and if it, for example, if the diagnosis is uncertain. But what about the diagnosis? It is by what? The diagnosis is by histology, as we mentioned here. Okay. For the treatment, The treatment patient should be informed about the condition and given written information. Patients should be made aware of the small risk of neoplastic change. They should be advised to contact the doctor if they notice a change in appearance of texture or texture even, for example, lump or hardening of the skin, or if there is a major change in symptoms. Okay, this is about the general advice. The recommended regimen is, as we know, and this is area of exam, and no exam without clobetasol propionate. No exam without this. Okay, so the ultra potent topical steroid, which is clobetasol propionate 0.05. Various regimen are used. One of the most common being daily use for 1 month, alternate day for 1 month, twice weekly for 1 month, with a review at 3 months. Very important.
No voice, ma'am.
Genital skin, because of the reduced need for preservative in an ointment base, and hence less risk of secondary contact allergy. There is no voice. Hello? No voice?
Now good.
Please repeat from this slide. It got there was no voice. Now okay.
Which one? The previous one?
Just repeat from the beginning.
Okay. Okay. So as we said, regarding the treatment, there is a general advice. My voice is clear right now?
From next slide.
Yes.
Next,
Yes,
yes,
ma'am,
this slide
now
has
clear.
been explained, ma'am. Next
Next
slide.
slide.
Okay. So 30 milligram ultra potent steroid should last at least 3 months ointment basis. And ointment bases are much better to use on the anogenital skin because of the reduced need for preservative in an ointment base, and hence less risk of secondary contact allergy. Approximately 4 to 10% of women with anogenital relation sclerosis will have symptoms that do not improve with topical ultra potent steroid. Steroid resistant disease, this is also SBA and recall exam question. Okay, 4 to 10% the steroid resistant disease. The alternative regimen, which is an ultra potent topical steroid with antibacterial and antifungal, for example, Dermovate, or generic equivalent like clobetasol with neomycin and nystatin, or an alternative preparation that combats secondary infections such as fusible cream, may be appropriate if secondary infection is a concern. Okay, so you can apply, as we said from the start, the ultra potent steroid, and also there is alternative. It include ultra potent topical steroid with antibacterial and antifungal. Okay, and it is most likely used if there is secondary infection is a concern, and this should only be used for a short period of time to clear infection. For the research finding and analyzing treatment, okay, topical calcineurin inhibitor. This is not a licensed medication, which is tacrolimus, 0.1%, has been shown to be effective when used for 16 to 24 weeks. Oral retinoid, which is acetoretinase, may be effective in severe recalcitrant disease, but should only be given by a dermatologist. Okay, so means that in difficult cases, in severe, for example, disease, should be given by dermatologist, and experience in the use of this agent. They are severely teratogenic, and pregnancy must be avoided for 2 years after finishing treatment. Okay. Also, ultraviolet phototherapy has been also reported as successful in small number of people. Number of cases, okay? For the pregnancy and breastfeeding, topical steroids are safe to use while pregnant or breastfeeding. Topical calcineurin inhibitors are contraindicated while pregnant or breastfeeding. Retinoids are absolutely contraindicated, as we know, during the pregnancy and for at least 2 years before, and they should be used with caution in female of childbearing age. So topical steroid, it can be used, but regarding the tacrolimus and retinoid, okay, tacrolimus is in contraindicated, but retinoid is absolutely contraindicated. Okay. Onward referral criteria, those with active disease, for example, when to refer means if you have active disease which has not responded adequately to a treatment, should be referred direct to specialized vulval clinic. For example, if you have a patient who developed differentiated or undifferentiated VIN or an squamous cell carcinoma on a background of lichen sclerosis, this should be also follow up in a specialized vulval clinic. The last thing is the surgery, and this should only be used for treatment of coexistent VIN, squamous cell cancer or fusion. Okay, and in this case disease tend to recur around the scar. Okay, for the follow-up, most likely follow up after 3 months to assess response. As we said that we give the medication for 3 months. After 3 months, we will assess her response to treatment, so that stable disease should be reviewed annually, and this can be done by the general practitioner in those with well-controlled disease. This must be communicated to the patient and GB by the clinic. So the patient, most likely it will be referred to, as we said, to gynecologist, gum clinic, and all these things. The medication now given to the patient. Okay, so the follow-up, for the follow-up, most likely the specialist will write for the GB the case and what given for the patient, and then he will send her for the GB to assess her response to treatment. Okay, patients should be informed that if they notice the development of a lump, sore area, change in symptom, or change in the appearance, they should prompt medical review. Just let the azan.
No voice.
Yes, no voice.
There is no voice, yeah?
Yes,
She has left for Azan.
Yes, hello.
That's
Still the azan.
silent.
Yeah, just wait azan. Yes, hello? Hello? Yes? So for the follow-up, for the follow-up, as we said, we, for example, the patient prescribe the specialist, the gynecologist, or the gum clinic, or whatever, who put for her the medicine. Okay, the follow-up for assessment of the response to treatment, it will be by the referral to the GB. So in the clinic of the GB or the surgery. Okay, so that the follow-up for this condition and how response to treatment. And also patient should be informed during the treatment, should be informed that if they notice the development of a lump, sore area, change in the symptoms, or change even in the appearance, they should prompt medical review. Okay, biopsy should be performed in patient not respond to an initial course of steroid treatment, and if raised lesion develop. This is, I think, one of the exam question, that if raised lesion, this is indication for biopsy, or failure of the initial treatment of steroid treatment, also this is an indication for a biopsy. Okay, so now finish the Lichen sclerosis. Now we will go for the Lichen planus, also exam question. No exam without Lichen planus and Lichen sclerosis as well. So Lichen planus is an inflammatory disorder with manifestation on the skin, genital and oral mucous membrane, and this is always come in the exam, if or remember. Okay, it is how you will know that it is in the genital and oral mucous membrane. More rarely, if it can affect the lacrimal duct, esophagus, and external auditory meatus, and it is an inflammatory condition of unknown pathogen. But it is probably an immunological response by T cells activated as yet an unidentified antigen. Okay, so if in the exam or SBA said to you that it is B cell or T helper or T cell, you should know that it is T cell. Okay, it is the same like Lichen sclerosis, unknown pathogen, but also it have an immunological element. Okay, so and also the second thing is that this is very important, oral mucous membrane. This is you will know it by this in the question, in the scenario. For the clinical feature, it is itching, irritation, soreness, the same I think like sclerosis, dyspareunia, urinary symptoms. Please other mute. Please other mute.
Muted.
So for the clinical feature and symptoms, please other mute. So for the symptoms, we said that itching, irritation, soreness, dyspareunia, urinary symptoms, and vaginal discharge. I think vaginal discharge is what not there in the Lichen sclerosis. Am I right? Hello, you are with me? Yeah,
Yes.
vaginal discharge was not
Yes,
there.
ma'am.
Yes, yes.
Yeah, so please concentrate
Yes,
with me
ma'am.
because no time. Yani, make it like a revision for you. Okay? Make it like a revision. So be with me. Yeah. So vaginal discharge is new in this Lichen planus. So it is one of the things that you know that this is Lichen planus. Okay. Even the for oral mucus, you can, if you found vaginal discharge, you can tell that this is Lichen planus. Okay. And it can be also asymptomatic. Also, it can be asymptomatic. Sorry, just 1 minute. Just 1 minute. Yes. So this is the lichen planus, as we said, oral mucous membrane. It is inflammatory autoimmune also, and this is vaginal discharge, which is the characteristic. Okay. So let's go for the next. This is lichen planus of the labia majora. Note the presence of multiple well-defined pink papule in the labia majora. Okay. Okay. So what are the signs of the sign of the the signs and genital lesion of the lichen planus may be, what is the sign of the lichen planus? Okay, the anogenital lesion of the lichen planus may be divided into 3 parts. Very important, this 3 parts group. Okay, the first one is the classical one, which is the typical papule. So papule, this is another what key papule for the lichen planus. Take care, okay? Will be found on the keratinized anogenital skin with or without striae on the inner aspect of the vulva. There is hyperpigmentation, another key. Frequently follow their resolution, particularly those with dark skin. And this type of lichen planus may be asymptomatic. Okay? So papule, keratinized, hyperpigmentation, all these features. Okay? So this is the classical one. The hypertrophic one, these lesions are relatively rare and can be difficult to diagnose. They particularly affect the perineum and the perianal area, presenting as thickened warty plaque, which may become ulcerated, infected, and painful. Because of these features, they can mimic malignancy. So they do not appear to be accompanied by vaginal lesion. This is hard key, not accompanied by vaginal lesion. This is for the hypertrophic. Okay, so we have classical, hypertrophic. The classical papule, keratinized, hyperpigmentation in the dark skin, these things. Hypertrophic, which is what? It is thickened, warty plaque, ulcerated, infected, painful, mimic malignancy, not involves the vaginal lesion. Okay, this is for the hypertrophic. The third one, the erosive. What about the erosive? This is the most common subtype to cause vulval symptoms. The most common subtype. The mucosal surface are eroded. At the edge of the erosion, the epithelium is mauve and a pale network, which is Wickham striae, which is a characteristic of this lichen planus. And in the question, if you found Wickham striae, this is planus, yani for sure. Not go for anything else. Okay? Lichen striae, it is characteristic of the lichen planus, Wickham striae, this one. In this type, the vaginal lesion in erosive are important to recognize early and start treatment, as they can lead to scarring and complete stenosis. Okay? So for the erosive, there is Wickham's striae. There is lead to scarring and complete stenosis of the vagina. So mean that there is involvement of the vagina. Opposite for, yani, not like the previous one, which is the vagina is intact. And here the lesion consists of friable telangiectasia. This is also characteristic. Telangiectasia means new blood vessels with patchy erythema, which are responsible for the common symptoms of postcoital bleeding, dyspareunia, and of variable discharge, which is often serosanguineous. So now we get another symptoms, which is postcoital bleeding, dyspareunia, and a variable discharge. Okay? So previous, we get new one, which is the vaginal discharge. Now we have postcoital bleeding, dyspareunia, and variable discharge, which is often serosanguineous. And the erosive one is characteristic with Wickham's striae, and there is involvement of the vagina. Okay? Take care. As erosive heal, sensitiate and scarring can develop. If the erosion is healed, this will develop sensitiate and scarring. And this type is also seen in the oral mucosa, although sensitiate are uncommon. The term vulvovaginal gingival syndrome is used when erosive disease occurs in these three sites. The presenting symptoms is usually of pain and soreness. Okay? The complication of the Lichen planus is scarring, including vulval vaginal sensitiate, development of squamous cell cancer, which is here 3%. Take care. This can come. What about the Lichen sclerosis? Anyone can tell me?
5.1.
Less than
Less
5%.
or like,
Less than
yeah,
5.
exactly. But here it's 3%. This is very important. Okay, take care. For the diagnosis, the characteristic clinical appearance, involvement of the vagina, exclude the Lichen sclerosis. Take care. Involvement of the vagina, exclude Lichen sclerosis. Means that the Lichen sclerosis, there is no anything with the vagina. Okay? Skin changes elsewhere can be helpful, but overlap between Lichen planus and Lichen sclerosis is described. Immunobolus disorders such as the pemphigus can look clinically similar to erosive Lichen planus, and histology of the vulval biopsy, this is regarding the diagnosis, the same. It will be histology of the biopsy, and it show irregular tooth acanthosis, increased granular layer and basal cell liquefaction, and band-like dermal infiltrate, mainly lymphatic. Take care. Very important. Okay? So, irregular tooth acanthosis, this is for the histology biopsy. Okay? Increased granular layer and basal cell liquefaction. And I will tell you all the cases that have liquefaction later on. The differential of liquefaction, okay? Band-like dermal infiltrate, mainly lymphatic. This is for the Lichen planus. The further investigation with what we can do, like before, we will do biopsy, we will do investigation if clinical indicator for the autoimmune disease, we will do skin swab, all these things, patch test, all this like the previous scenario, which is Lichen sclerosis, okay? But here there is direct immunofluorescence, which is new, okay? So biopsy is necessary if the diagnosis is uncertain or coexistent. VIN squamous cell cancer is suspected. Direct immunofluorescence should be performed if an immunobolus disease is considered in the differential diagnosis. Okay, so if this is patch test, which is a test for allergy. Okay, they make like an area in your skin, multiple area. It will be marked, and then we will put the allergen on this area, and they will see which allergen, which is the patient, the skin have an allergy or have skin irritation for this. Okay. Direct immunofluorescence, as we said, this is characteristic and should be performed if an immunobolus. I will send you picture for the patch test. Okay, I don't know who doctora, but what is the name of the doctora, but I will send for you in the group. Okay, for this patch test. So direct immunofluorescence should be performed if an immunobolus disease is considered as a differential diagnosis, and only 25% are classical on biopsy. So the 25% is the classical. As Amri mentioned before, is the erosive is the most common. Am I right? If you remember.
Yes.
Yeah. So 25% is just for the classical type. Okay. Investigation for autoimmune disease, especially if the thyroid, T4 and TSH, if there is any suspicion of abnormality, skin swab to exclude secondary infection, especially if case of excoriated lesion, and patch testing if secondary allergy is suspected. Whilst a link with hepatitis C and sometimes B have been noted in some countries, there is no evidence of increased incidence in the UK, and routine screening is not thought necessary. So no need to screen for hepatitis B or C, and because no evidence of increased incidence with this. Okay. For the treatment, as we said, general advice first. So patient should be systematic when management, even in the bring for you in the question, be systematic. There is general advice and then medication like this, the follow-up. So be systematic. Okay, so the first thing is a general advice. Patient should be informed about the condition, given her written information, the patient information leaflet, which is it will be in a simple or in simple language for the patient. Okay, so that it can understand what is written in the patient information leaflet. There will be no jargon, means that no medical terminology. Okay, so patients should be made aware of the small risk of neoplastic change, and they should be advised to contact the doctor if they notice, for example, change in appearance or texture, for example, lump or hardening of the skin, as before we said. Then the recommended regimen, the same, ultra potent topical steroid, clobetazol, and there is no evidence on the optimal regimen. The maintenance treatment may be required and can either be with weaker steroid preparation or less frequent use of potent steroid. Vaginal corticosteroid, okay, to the vagina is not easy, and a proprietary preparation containing hydrocortisone cauliform introduced with an applicator is useful, because the delivery of corticosteroid, as he mentioned, it's not easy as per the guideline. Okay, so there is preparation with hydrocortisone cauliform, which is introduced with an applicator, is useful. Prednisolone substitute may use in more severe cases. So prednisolone can be used with severe cases. So ultra-potent topical steroid, vaginal steroid, inform if it is not easy, we can use this hydrocortisone. And the last thing is that we can use the prednisolone substitute in severe cases. Okay. For the alternative, very thing as before, we said that we can use it with antibacterial and antifungal, for example, Dermovate or generic equivalent. For example, if there is any evidence of secondary infection, and this should only be used for a short period of time. Pregnancy and breastfeeding, topical steroids are safe to use while pregnant or breastfeeding. And as we said that topical tacrolimus is contraindicated while pregnant or... Hello? My voice is not clear?
Clear.
Clear, ma'am, clear.
Yeah, so retinoid are absolutely contraindicated. This is very important. And there is, I think, one of the talk article about retinoid, just you know that it's absolutely contraindicated, and for at least 2 years before. And they should be used with caution in female of childbearing age for this retinoid. Okay? For the referral, we can refer to the MDT, Vulval Clinic, is recommended for erosive disease, and those in whom systemic therapy is considered. Okay, in the vulvovaginal gingival syndrome, there is general agreement that azathioprine, dapsone, crizofulvine, chloroquine, and minocycline, all tried empirically, are of little or no benefit. This is area of SBA. It can come in you in one of the SBA line, okay, one of the options. So take care. In the vulvovaginal gingival syndrome, there is general agreement that the azathioprine, dapsone, crizofulvine, chloroquine, minocycline, all tried empirically, are of little or no benefit. So that they are indicated to be referred to the MDT clinic, vulval clinic. Okay. Oral cyclosporine may be considered. Retinoid can be very helpful in hypertrophic cases. So if you suspect from the scenario that there is hypertrophic cases, this is hypertrophic, and they ask you for management, you should choose retinoid. But take care also, maybe she's pregnant or in childbearing age, take care. So each scenario. Okay. So retinoid can be very helpful in, as we said, each scenario take care that see the age of the patient, see if she's pregnant or suspected that she is pregnant. In the scenario, you should take care in the question. The oral steroids are used, for example, prednisolone, 40 mg per day, tapered off over a few weeks, and courses can be repeated as necessary for severe flare. The new biological agents have been used in oral and cutaneous disease. Basifliximab has been found to be effective, but its use has not been evaluated in vulval disease. All these potential toxic therapies used need careful monitoring and are best supervised by a dermatologist in the context of a specialized clinic. So for the biological agent, for the basifliximab, this needs to be by dermatologist. And also, the effectiveness is still need to be more. We need more evidence, okay? Because it has not been evaluated in vulval disease. For the follow-up, as we said, at 2 to 3 months to assess the response to treatment. Active disease should be assessed as clinically required. Okay. The erosive one needs long-term specialized follow-up. As we said, that the erosive one, it should be follow-up not by the GP. Need specialized follow-up. Okay. Stable disease should be reviewed annually, except in well-counseled patients who control their symptoms well. If review is by the general practitioner, this should be communicated to the patient and GP by the clinic. Patients should be informed that if they notice the development of a lump or change in the appearance, they should seek medical advice urgently, because there is maybe there is any red flag for any sinister or cancer things. Okay, issue. Biopsy should be performed in patients who not respond to an initial course of treatment and if raised lesion develop. For the vulval eczema, this is the new. We finished now the vulval this one, lichen planus. Now we will go for the eczema. Take care. Okay, so for the lichen, for the vulval eczema, the etiology is eczematous and lichenified disease, and it's classified into 3: either atopic, allergic contact, or irritant contact. Okay, the atopic one is that the allergic type often seen in people who also have high fever or asthma. So mean that this allergic type due to allergen. Allergic contact due to skin contact to a substance that to which the individual is sensitive. Okay, irritant contact, which is due to skin contact with irritating chemicals, powder, cleaning agent. Okay, this is for the classification of the vulval eczema. Clinical feature including vulval itching, soreness. Signs are erythema, lichenification and excoriation, fissuring. Okay, the complication is that secondary infection. But if you see there is erythema, take care. Erythema. Okay. In the lichen planus, what we found? We found what?
Papules. Pink
Papule and
papules.
plaque. Papule and
Pink
plaque.
papules.
Yeah.
Plaque.
Yeah. Okay. So take care. These things actually, this is the thing that you differentiate with each other, because in the exam the time is very limited and you cannot differentiate by just see this erythema, خلاص, eczema. Okay. Because no time in the exam. Complication is secondary infection. Diagnosis, for example, set to you by clinical presentation and general examination of the skin to look for other sign of dermatitis. Take care. Fissuring like lichen sclerosis. The management, it will include patch test, biopsy, for example, if there is any atypical feature or failure to respond to treatment. And the recommended treatment is avoidance of any precipitating factor, use of emollient, soup, substitute, which is aqueous cream, shouldn't be applied as a moisturizer due to the risk of irritant effect, and hydromol can be a suitable alternative. So the management is avoidance of a precipitating factor, okay, and use of emollient soup substitute. For the topical corticosteroid for the eczema, the choice of the preparation will depend on the severity. You will give 1% hydrocortisone ointment in milder cases, or betamethasone valerate 0.025, or clobetazole propionate 0.05% for limited period of severe or leishonified. Okay. A combined preparation containing antifungal or antibiotic may be required if the secondary infection was suspected, and apply once daily. The same. So from the start, avoid irritating substance, and then use of the emollient soup, and then the topical corticosteroid, and the last thing, that combination of this corticosteroid with antifungal and antibiotic if you suspect, if there is any secondary infection is suspected. The follow-up as clinically required, and the long-term follow-up and psychological support may be needed in this case of eczema. Okay, psychological support in eczema. I didn't saw until now psychological support in Lichen sclerosis or Lichen planus. Psychological support is in where? Eczema. Patient should be given a full explanation of their condition with written information. Okay. It is clear till now? No?
Yes, ma'am, it is clear.
Okay, so let's go for the Lichen simplex. Yeah, Lichen simplex. Lichen simplex, the etiology is categorical into 4 main groups, which is underlying dermatosis, environmental factor, psychiatric disorder, and emotional tension. So this is the second psychiatric here. Okay, Lichen simplex and eczema. Okay, so underlying dermatosis, which is, for example, like atopic dermatitis, allergic contact, dermatitis, superficial fungal, tinea, and candidiasis, infections, systematic condition, causing pruritic, for example, renal failure, obstructive biliary disease, primary biliary cirrhosis, and primary sclerosing cholangitis, Hodgkin's lymphoma, hyper or hypothyroidism, and polycythemia bravera. All these things, if it come to you, put in your mind it is Lichen simplex. Okay. If, for example, say to you the patient have renal failure and she has this skin manifestation and it looks like it is most likely it will be Lichen simplex. Okay. So all these things, it will help you in the scenario. Environmental factor, heat, sweat, rubbing of the clothing, and other irritants such as harsh skincare products. All these also can be Lichen simplex. And anxiety, depression, obsessive compulsive disorder, and dissociative experience are often associated with this condition. And emotional tension, for example, in predisposed people, those who, for example, have underlying predisposition for atopic dermatitis, asthma, and allergic rhinitis, can induce itching and thus begin the chronic itch scratch cycle. Okay. Yes, we will go through quickly through it because not come more in the exam. Just there is some point you need to know. A clinical feature is itching and soreness. The sign is lichenifaction, which is thickened, slightly scaly, pale, or irisy colored skin with accentuation marking, maybe more marked on the side opposite the dominant hand, erosion and fissuring, excoriation as a result of the scratching, excoriation. Okay, so pubic hair is often lost in the area of scratching. This is very important. If he said to you that there is no hair, for example, in the area of monopubis, so this means most likely, because of this scratching, most likely this will be Lichen simplex. Take care. Okay. Pubic hair lost in the area of scratching, one of the things that can differentiate. Okay. Sorry. So the complication is secondary infection, and the diagnosis will be it will be the psoriasis of the vulva is usually less itchy, and lesions are bright red, often glass and well demarcated, and frequently involve the natal cleft. History including mental state examination were indicated. Yeah, general examination of the skin to look for other sign of psoriasis or lesion simplex elsewhere, because he put the psoriasis because it is very near for the lesion simplex. Okay, we will see now the difference after we will go for the psoriasis, but you should know that in psoriasis there is red, bright red, often glass and well demarcated, and frequently involves the natal cleft. My voice is clear?
Clear.
Yes. Yeah. So in psoriasis, bright red, often glass, and the well demarcated, and frequently involves the natal cleft. Okay. Management and investigation. Okay, so screening for infection, for example, Staphylococcus aureus and Candida albicans. You should do this. Okay, dermatological referral for consideration of patch testing, standard 23 standard battery and medicament. This is also with the dermatological referral. You no need to know about it. Ferritin, very important in this case. Biopsy. Okay, so all this it is investigation to be done for the lesion simplex. You need to screen for infection. You need to do a dermatological referral. You need to do a ferritin because it can be low ferritin. It can be a cause for lesion simplex, and the biopsy. The treatment and recommended treatment is avoidance of precipitating factor, use of emollient soap. Some people may have a reaction to aqueous cream when it is used as an emollient. Okay, so for this reason, it is recommended only as a soap substitute and not as an emollient. Okay, so here, use of emollient soap. Take care. Emollient soap. Okay, this is as irritant. So you need to use soup substitute, not an emollient soup. Okay, like before in the beginning of the guideline, he said that bubble bath also to be avoided. Okay, so take care. Emollient soup, bubble bath, this is should be avoided. Okay, so the topical corticosteroid which is used in the lesion simplex, which is a potent topical steroid, are required when treating lesion-fied area. For example, betamethasone or clobetasol for limited period. A combined preparation containing antifungal and or antibiotic may be required if secondary infection, as we know. A mildly anxiolytic in an anxiolytic because there is some element of psychological issue. So you can give an anxiolytic antihistamine such as hydroxyzine or doxycycline at night is helpful. The symptoms of pruritus often respond fairly quickly to a topical steroid, but unless the lichenification resolve, the itching scratch cycle will remain and the symptoms will recur. Okay? So the pruritus, it will not respond well for the topical steroid. If you give her, you will you will not suspect or you will not think that this itching will resolve immediately. It will take time because the itching scratch cycle will remain and the symptoms will recur. A graduated reduction in the frequency of application of the topical steroid is helpful over about 3 to 4 months. Cognitive behavioral therapy may be helpful if there are coexisting mental health issues. Okay. So now the things which have, for example, psychological issue or these things, it is now this one and the other one, which the simplex and
Eczema.
the
Eczema.
eczema. Yeah. Okay. Just I want to know that you are not sleeping. Okay. For the follow-up, the mild disease is as clinically required, and for the severe disease, when using potent topical steroid, 1 month then as required. Okay, the patient should be given a full explanation of their condition with written information. Now we will go for the psoriasis. The etiology of the psoriasis is a chronic inflammatory epidermal skin disease affecting approximately 2% of the general population. So 2% is psoriasis. Okay, this is a chronic inflammatory disease. Chronic inflammatory disease, not autoimmune until now. Okay, previous slide. This is for the follow-up of the simplex. We said that for the mild disease as clinically required, and for the severe disease, when using potent, 1 month, then as required. Okay, and the patient should be given a full explanation of their condition with written information. Okay, just I think better to have just 5 minutes or 10 minutes just to pray. Okay, hello. Okay. 10 minutes to pray. Okay.
Yes, ma'am.
Yeah, 10 minutes to pray.
Okay, doctor.
Yeah. Thank you. Hello? Yes, hello. So let's start with the vulval psoriasis. Welcome. Let's back. Okay, so vulval psoriasis also it can come in the question. Okay, in the exam, one of the question in the exam. Okay, so it's a chronic inflammatory epidermal skin. My voice is clear first. Hello, is my voice is clear? Yeah.
Yes,
So
ma'am.
Yes, ma'am, it's
yeah.
clear.
Yes, yes, clear.
Yeah, good. Okay, so psoriasis is a chronic inflammatory epidermal skin disease affecting approximately 2% of the general population, and it is may represent as part of the plaque or flexure psoriasis. This is the genital psoriasis, or rarely as the only area affected. Okay, so what about the clinical feature? It is vulval itching, soreness, and burning sensation. Don't forget, it is a chronic inflammatory epidermal skin. Affect 2% of the population. Regarding the sign, it have well demarcated brightly erythematous plaque, often symmetrical, frequently affects the natal cleft, usually lack scaling due to maceration. Okay? No scaling. Take care. Psoriasis, no scaling. Fissuring. There is scaling in which one we mentioned before? Anyone can remember?
Psoriasis.
Sclerosis. Lichen sclerosis.
Lichen sclerosis or allergic? It's the scaling with which one? Anyone remember? I think we said scaling in the planus, I think. Anyone remember? Planus. I think planus, yeah. So fissuring, and regarding the, yeah, exactly, the erosive one, there's a scaling. So take care. Here, there is no scaling. Usually lack scaling. That's why I'm asking you, because when I ask you question, this is actually the SBA and EMQ question. Why? Because I remember from the question in the EMQ, they can come with this, that there is no scaling. So if they write for you no scaling, you should put in your mind that it can be this psoriasis. Okay? Fissuring. Yeah, and the complication is that may be worsened due to Kovner effect by irritation from urine and tight-fitting clothes or sexual intercourse. Okay. For the diagnosis, it is clinical presentation as before, from the history or from the clinical examination and presentation, and from the general examination of the skin and the nail to look for other sign of psoriasis. The management is further investigation is as skin punch biopsy if the diagnosis is in doubt. So No histology here. Until now, he didn't say histology. Am I right? He said that skin punch biopsy. Maybe histology. No, it will be histology because this skin punch biopsy, so it will be sent for the lab to see what is the histology of this. Okay. The treatment, the recommended regimen, as we said, be systematic, avoidance of irritating factor, use of the emollient soup substitute, which is one of the irritating factor, topical corticosteroid, weak to moderate steroid are preferred, but if insufficient to induce a response, then intensive short-term potent steroids such as the clobetasol propionate 0.05 may be used, and a combined preparation containing antifungal and or antibiotic may be required if secondary infection is suspected, which is trimovate. And the coal tar preparation may be used alone or combined or alternated with topical steroid. However, these preparations can cause irritation and folliculitis. So take care. It can cause this coal tar preparation. It can cause this irritation and folliculitis. Vitamin D analog such as talketisol, citol alone or in combination with corticosteroid also. However, their usefulness may be limited by causing irritation, but also it can be one of the options. Okay, so avoiding of the irritating factor, topical steroid, the coal tar preparation, vitamin D analog like calcitol. Okay, this is for the psoriasis. The onward referral, the psoriasis need referral to MDT, vulval clinic, multidisciplinary vulval clinic is recommended for unresponsive or those in whom the systemic therapy is considered. Okay, so systemic treatment is considered if required for severe cases, and extensive psoriasis may help genital lesion, but not recommended for isolated genital psoriasis. Okay, what about the follow-up? The mild disease as clinically required, severe disease, for example, when using potent topical steroid 1 month, then as required. Patient should be given a full explanation of their condition with written information. Okay? Then we will go for the VIN. Still you are tolerating?
Yes, of course.
Yes.
Yes, of course. We don't have option, Dr. Rasha. This exam is near.
Yeah, of course. Of course you are.
Wallahi, I choose this topic because I know it is need to be revised before the exam, and you cannot, maybe sometimes you cannot revise it alone. So if you done كده, it will be useful for you.
Yes, thank you very much. Yes.
Welcome,
I think even part 3, will get benefit if they listen to this. Yeah, thank you very much.
You are welcome, my dear. So for the VIN, this is
sorry, Dr. Rasha, Dr. Rasha.
Yes. Yes.
I want to ask just about Koebner effect in psoriasis. What is Koebner effect? Sorry.
Koebner effect. What we said here, what we said before. It is irritation by urine. In case of, if there is, for example, fissuring, there is maceration, there is, for example, still recording, still recording, okay? Or it's erythema plaque, or these things all, it can be this condition worsened by irritation by urine, or for example, tightness closes, okay? This Koebner effect is the irritation, which will happen, okay?
Okay, Doctor, thank you.
You're welcome. So now for the VIN, also very important, and it coming with us also in our exam, the third part. very important, the VIN, one of the station, okay? So VIN, this is a vulval skin condition which may become cancerous, okay? Take care. It is vulval skin condition which may become cancerous if left untreated. It is confirmed by histological diagnosis, okay? So it is histology diagnosis. In the gum clinic, the commonest etiological agent is the human papillomavirus. And this is known as usual type and is mainly associated with human papillomavirus 16. Take care, this is exam area, okay? Human papillomavirus 16, which is the cause of the most mainly association with it, with the VIN. Okay, human papillomavirus 16. A second type, generally not human papillomavirus related, occurs in conjunction with lichen sclerosis or lichen planus, known as differentiated type. The risk of progression to squamous cell cancer is much greater with the differentiated type, okay, of VIN, and needs specialized management. VIN is commoner in immunocompromised women, and smoking is also a risk factor, okay? So there is association with human papillomavirus, association with an immunocompromised, most likely most risky for this VIN. The smoking is also a risk factor. Also, the differentiated type, which is related to the lichen sclerosis or lichen planus, also this is high risk to go for squamous cell cancer. This is the new 2018, the FIGO, I think, for the VIN, okay? It shows that, for example, in VIN, this is 2019, this is a classification, okay? So a minute. The VIN terminology change now, it become like, for the VIN1, it is LSIL, which is, so a minute. Which is the low-grade squamous intraepithelial lesion, and HSIL, which is the high-grade squamous intraepithelial lesion, and the differentiated one, which is DVIN, okay? So let's go back. This is the LSIL, this is the VIN1. The VIN2 and 3, this is HSIL, the high. And for the differentiated one, is differentiated VIN, not the name not change. Okay, for the HSIL, before was VIN, QWERTY, bacilloid, and mixed. This is now become as HSIL. Okay, so this is a new terminology. Take care. For the VIN, it is this one. For the VIN2 and 3, it is HSIL. For the differentiated, it's the same. Okay. So currently, such lesions arising from the vulva and the anus are all included and are named as lower anogenital squamous intraepithelial lesion under this classification. We have 3 parts, which we said before. For the VIN1, it is low-grade squamous intraepithelial lesion, and for the V2 and 3, it is high-grade squamous intraepithelial lesion, and for the differentiated one, is differentiated variant. Okay? For the differentiated one, it is represent less than 5% of the pre-neoplastic lesion of the vulva. Okay, means that it can progress to a cancer. This is the less than 5% of the differentiated one. We said before the differentiated one is related to what? To the lichen planus and the yeah, exactly. So less than 5% of the pre-neoplastic lesion of the vulva represented by the DVIN. However, it is characterized by a higher rate of progression to squamous vulvar carcinoma, shorter time interval to progression, and higher recurrence rate than HSIL, and it is rarely associated with persistent human papillomavirus infection less than 2%. Okay, very important. So less than 5%, characterized by higher rate of progression to squamous vulvar cancer, shorter time interval to progression, higher recurrence rate than the HSIL, and it is rarely associated with persistent HPV, less than 2%. Okay, because from the start we said that it is related to lichen sclerosis and lichen planus. For the clinical features of the VIN, lump, burning and itching irritation, asymptomatic and pain. This is all the clinical feature. Lumps, burning and itching irritation, asymptomatic and pain. Regarding the sign, clinical appearance is very variable, and it includes raised white erythematous or pigmented lesion occur, and this may be warty, moist, or eroded. Pigmented lesion were previously known as boinoid papulosis. Okay, and multifocal lesion are common. Take care. There is warty, moist, eroded, pigmented lesion, raised white, erythematous or pigmented lesion. All these are the things for the VIN. Okay. So erythema here, don't forget. Erythema here before was in the simplex. Do you remember? Or in the eczema. The erythema where it was? The eczema. Yeah, in the eczema. Yeah. Okay. So here also there is erythema. So take care. And there is pigmentation like planus. Okay. Raised white like sclerosis. Warty like, for example, a cancer or whatever. Okay. Erosion and these things. So all things are in this VIN. Okay. Raised white, most likely it will be if there is, for example, hidden lichen sclerosis. Pigmented if there is, for example, hidden, lichen planus. Okay. So all these things. Warty, most likely it will go for a cancer. Yeah. Okay. So complication is the development of squamous cell cancer has been reported 9% and 18.5% of the women. This is very important that it will develop to cancer. And the recurrence is common, and progression to cancer can occur following previous treatment. Okay. Psychosexual consequences have also been described, and especially following surgical treatment. Okay. Just 1 minute. Okay, so as we said, the development of squamous cell cancer, which will be between 9 to 18.5, and the recurrence is common. Progression to cancer can occur following previous treatment, and the psychosexual consequence, okay, even after treatment, especially if you will go to treat her surgically, because there will be scarring and there will be interfere with her sexual symptoms, okay. So the diagnosis is biopsy, which is histology shows loss of organization of the squamous epithelium with a variable degree of cytological atopia, which is graded as undifferentiated or differentiated and by depth. So multiple biopsy may be required as there is a risk of missing invasive disease. Again, biopsy, the diagnosis is by histology through biopsy. It will show loss of organization of the squamous epithelium with a variable degree of cytological atopia, which is graded as undifferentiated or differentiated and by depth. And multiple biopsy may be required as there is a risk of missing invasive disease. So we may need multiple biopsy because maybe there is a missing invasive disease. The management and further investigation ensure that cervical cytology remain up to date. Okay, up to date. One of the scenario in the, inshallah, if you pass this exam, one of the cases of the station, as I mentioned to you, was structured discussion case, and it showed that the patient she neglect herself, and I think she was HIV, and we know that the HIV patient need to for annually cervical screening, so that she came with vulval this VIN. Okay, so the one of the her yeah, still recording. One of the management option is that to do for her immediate cytology, okay, cervical cytology. So take care. In VIN, you should ask the patient about her history if she's follow with her cytological cervical screening program. Okay, so you should ensure that this is remain up to date, and there is an association with CIN, and is probably only applicable to those due to human papillomavirus. All patients with VIN should be referred for up-to-date colposcopy to exclude CIN and VIN, and if there are any perianal lesion, refer for anoscopy is recommended, because it may be any hidden or sinister issue. Is it clear till now? Hello?
Yes.
Yes, clear.
Okay. Regarding the treatment, most study and research relate to full thickness VIN. Just 1 minute. Yes, sorry, just my small daughter keep nagging and keep asking, open the door and close. Okay, so most study and researches relate to full thickness, as we said, regarding the treatment. So most study and researches relate to full thickness VIN. Full thickness VIN. Multifocal lesion can be treated in the same manner as single lesion, but may have a higher recurrence rate. Okay, so the multifocal have a higher rate of recurrency. Okay, the recommended regimen is that, as we know, the local excision, this is the first one, and this is the treatment of choice for a small, well circumscribed lesion, as it has the lowest rate of recurrence on follow-up. Okay, so local excision, this first one. Then you will go for imiquimod cream, 5%, is a partial and complete clinical and histological regression has been shown in a small study, but treatment limited by side effect. This is imiquimod cream. It show that it have histological and clinical recovery. Okay, but the treatment is limited by side effect, because there is side effect with this imiquimod cream. Only short-term follow-up data is available, and this is an unlicensed indication. You should tell that this is you should know that it's unlicensed for this issue, for this indication. Okay, so imiquimod cream is unlicensed. Even in the third part, inshallah, if you go, you should tell that it is unlicensed indication. I mean, okay. For the vulvectomy, this has been effective, but recurrence may occur, and a function and cosmosis will be impaired. Okay, so even in the counseling of the woman, you should tell her that if we do vulvectomy, there will be a problem with cosmosis, so that you need maybe cosmetic surgery. Okay. So now, what about the until now the recommended regimen? What is it? Okay, so The first thing is that local excision. So you need to remove this part. This is the first thing because there is a high progression to cancer. So we need to relieve this or remove this. So this is local excision. Okay, and they need follow-up because if we not remove or we not exist, this will be high risk for recurrence on follow-up. So need to be local excision, especially for the small well circumcised area. Okay, and emicomoid cream, partial and complete clinical and histological regression. Actually, emicomoid cream, I didn't see that it is contraindicated. I didn't hear that it is contraindicated in pregnancy. Okay. No any evidence that it tells that it is not. I think it can be used with pregnancy, especially with this 5% is low. Okay.
It is under which group, Dr. Rasha? Steroid, emicomoid? Under which group? Sorry, emicomoid. It is steroid or which group?
I think it is. I think it is. I think acid, some acid. Like trichloroacetic, like trichloroacetic acid or something like this. I think so. If anyone know, can tell us. I think it is immune modifier or something with immunity. It work. Anyone have any idea about it? He can tell us. Yeah, it's immunomodulator, exactly. Yeah, it works with the immune system, as I said to you. Okay. Yeah. So, yeah, but there is no evidence that it is cannot be used in pregnancy. No, nothing. Is there evidence? If you have any evidence about it not to be used in pregnancy, just please send for us. Okay. I don't know who write in the.
I got the information that it's contraindicated during pregnancy, but it is not the acid. The acid is another treatment. This is why in the wards, in the management of wards, if the patient is pregnant, the management by cauterization is better than using it. I think. I'm not sure.
It is absolutely contraindicated. I mean.
No, it's not absolute. It's not written that it's absolute. It's written that
it is better to be avoided. You mean?
Yes.
Yeah. Better to be avoided. Yes, exactly. Okay, thank you, Dr. Khalid, I think, or yeah, thank you. Okay, so this is emicomoid. It is, as we said, it is what? It is immunomodulator. Okay, and for partial and complete clinical and histological regression, it shows this. Okay, and but the treatment limited by side effect because it's have side effect. Okay, for the vulvectomy, as we said, when you counsel the woman, you should tell her that there have been effective. This is effective, but recurrence may occur and function and cosmosis will be impaired. Cosmosis will be impaired. Okay, very important. For the divine, which is excision with 0.5 to 1% cm margin, constitutes the treatment of choice. This is for the differentiated type. Okay, the excision with 0.5 to 1 cm margin constitutes the treatment of choice. This is the new Vigo. Okay, this is a new one written like this because as I told you, I collect from many areas. From the talk, from the guideline, the NICE guideline, and also from the okay. So as we said, this is a differentiated type. The treatment of choice is the excision with 0.5 to 1 cm margin. Take care. Okay. For the differentiated VIN, excision is the treatment of choice. Okay, and it is with 0.5 to 1 cm margin. For the high HSCIL, squamous interstitial neoplasia, this is simple excision with 5 millimeter margin and 4 millimeter depth. Okay. And alternative option are carbon dioxide laser, topical imiquimod, and CEDO4, which is vial, which all have same response rate at 6 months. And independent of the chosen treatment and margin status, there is a risk of recurrence up to 30 to 40%. And therefore, a close follow-up is recommended for at least 2 to 3 years. Okay? So for the differentiated, excision is a treatment of choice. For the high, which is type 1 or type 2 or type 3, I mean, this is simple excision with 5 mm margin and 4 mm tips. And there's alternative like carbon dioxide laser, topical imiquimod, all these things can be used here. And there is independent of the chosen treatment and margin, there is a risk of recurrence. Yani even, yani not all the treatment, they don't have risk of recurrence. Independent of the chosen treatment and margin status, there is a risk of recurrence up to 30 to 40%. Okay, and therefore a close follow-up needed, recommended for at least 2 to 3 years. So this need to be follow up with the vulval clinic with at least 2 to 3 years, not to be sent for.
Ma'am, there is no depth for Devin. There is no depth, like there's a 4 mm depth for excision of HCl. So there is no defined criteria of depth in Devin.
This is from the FIGO. In the FIGO written like this.
Okay, ma'am.
Yeah. For the alternative regimen, okay, for this, you can use, for example, local destruction. For example, a variety of techniques have been evaluated, including carbon dioxide laser and ultrasonic surgical aspiration, photodynamic therapy, cryotherapy, laser, and there are anecdotal report of treatment with dysthermy. Involvement of skin appendage can occur, and recurrence may ensure if the appropriate depth of treatment is not achieved. The recurrence rate of follow-up tend to be higher than for excision. So for excision, the recurrence rate is low. But for the excision, the cosmosis is usually, I think, not good. The recurrence rate at follow-up tend to be higher than for excision. But cosmosis is usually good for the excision, I mean. Yeah, for excision. Okay? Because you will take the area, you remove the area. That's why it will be higher. Okay, but for the vulvectomy, before he said that there is a problem with cosmosis and the function. Okay, for the 5-fluoro uracil cream may lead to resolution of the some lesion, but results are variable and side effects are common. Okay.
Yes, doctor. I think I think in a high recurrence for the that اللي هي alternative اللي هي destructive method. It will be had high recurrence and good
cosmosis is good. Yeah. But even I mean for the vulvectomy, for the local excision, the cosmosis and no, I mean for the alternative. Okay, the recurrence is high, but the cosmosis is good because you will not take. You will not. Yeah. But for the excision, if you take excision, the recurrence will be low, but the cosmosis is not good. It's like this. Okay. Yeah.
Thanks.
You're welcome. So no consensus on usefulness or regimen or any regimen. And there is no consensus that this is best or this is best. Okay. This is an unlicensed indication. Hello. Okay, so supervision, some lesion will spontaneously regress, and this may be best policy for partial sickness PIN. However, there is a risk of progression, and patients should be made aware of this. Okay, so no consensus that this is best or this is best, but just it is from evidence. Okay, pregnancy and breastfeeding, imiquimod and 5-fluoro uracil are not licensed in pregnancy. as I said here, for the pregnancy and breastfeeding, the emiquimoid and 5-fluorouracil cream are not licensed in pregnancy, are not licensed, okay? The onward refer, it's not licensed, but not that means that it is contraindicated, not licensed, because some medication are not licensed, okay? Even in pregnancy. But it not means that we cannot use it, okay? For the emiquimoid especially, I mean. For the referral, cases should be assessed in MDT, I mean multidisciplinary vulval clinic, or have input from gynae regarding as assessment for surgical excision. Okay, and for the follow-up, the close follow-up is mandatory, although resolution may occur VIN3, particularly has a significant rate of progression, which is 6.5% in one study. Okay, the follow-up of cases until 5 years after resolution. Okay, so for the vulval pain, sorry, you get tired or hello? We can complete?
Yes, ma'am.
Yes.
Okay. So for the vulval pain, this is, as we know, for the vulvodynia, and this also they like this topic actually. They like it too much for this vulval pain, and many SB and EMQ came with this topic for the vulval pain. Okay, so the vulval pain is International Society for the Study of the Vulvovaginal Disease define the vulvodynia as a vulval discomfort, most often described as burning pain occurring in the absence of relevant visible finding or specific clinically identifiable neurological disorder. This is yani, for no cause. Just it is like burning pain occurring in the absence of any cause. Okay? This is for the vulvodynia. For the vulvodynia is categorized as generalized or localized. Okay? Provoke or unprovoke, or a mixture of the two. So generalized in all the area, localized in one area, provoked by any stimulant, or unprovoked, or a mixture of both. For the localized one, provoked, the localized provoke, vulvodynia, which is vestibulodynia, the etiology is likely to be multifactorial, and a history of vulvovaginal candidiasis, usually recurrent, is the most commonly reported feature. Okay, this is for the vestibulodynia. Most likely it is multifactorial. It is localized provoke. The provoke one, the stimulant was the vulvovaginal candidiasis, the history. Okay, and it will be usually recurrent. It's the most commonly reported feature. Okay. The clinical feature and symptoms, the vulval pain frequently felt as the introitus at penetration during sexual intercourse or on insertion of the tampon, and there is usually a long history. Okay. The signs are focal tenderness elicited by gentle application of a cotton wool tip, but at the introitus or around the clitoris. There are no signs of an acute inflammatory process, and the complication, it includes sexual dysfunction and psychological morbidity. Okay, so for this, the complication are sexual dysfunction and psychological morbidity. My voice is not clear?
Clear, ma'am.
Just clear.
Okay. So this is the symptoms and sign. We said that it is tenderness. This is by gentle application, and this is the complication that the patient came to you with sexual dysfunction, okay, or psychological morbidity. She feared from sexual penetration. Okay, this is most likely the history. For the diagnosis, it is clinical diagnosis made on history and examination, and the management and further investigation, including after exclusion of other treatable causes, no further investigation is required. Okay? As the British Society for the Study of the Vulval Disease recommend an MDT approach to patient care, and that combining treatment can be helpful in dealing with different aspects of vulval pain. So the management of this local vulvodynia is what? MDT. Okay, multidisciplinary approach. The recommended treatment or regimen is the same. Avoid the irritant factor, use of the emollient substitute, topical local anesthetist. So in the scenario, if she bring to you that the patient she's afraid to do sex or from penetration or these things, the first medication you will give for her is the topical local anesthesia. Okay? Topical local anesthesia, for example, 5%. Lidocaine ointment or 2% lidocaine gel should be used with caution as irritation may be caused. Okay? The application should be made 15 to 20 minutes prior to penetrative sex, and washing off the lidocaine just before sex or the use of the condom by the partner can reduce the risk of transfer resulting in penile numbness. Okay? And oral contact should be avoided. Is it clear? Okay? Is it clear till now? Hello? Is my voice
Yes, ma'am,
clear?
it is clear.
Yes, yes, clear. Yes, clear.
It's clear,
Yeah.
ma'am.
So this is for vestibulodynia. This medication, this management is for the vestibulodynia. Okay? That you will go for local anesthesia, I mean, by 5% lidocaine, because in the scenario it can come to you, one of the cases in the scenario. Okay? Most likely they will bring for you that the case, for example, have this problem and she cannot do sex and afraid from penetration and these things. So you will give the first thing is that avoidance of irritation factor, use of emollient, and you will go for topical local anesthetist. Okay, 5% lidocaine ointment or 2% lidocaine gel. 15 to 20 minutes prior to penetrative sex. Okay. For the physical therapy, you can do physical therapy like pelvic floor muscle biofeedback. Okay, vaginal transcutaneous nerve stimulation TENS, or vaginal dilator, maybe there is any narrowing in the area. Okay, and cognitive behavioral therapy. All these things, it can help with the vestibulodynia. Okay. The alternative regimen is that pain modifier. The benefit of drugs such as tricyclic antidepressant, gabapentin and pregabalin is not clear, but the amitriptyline gradually titrated from 10 mg up to 100 mg according to response and side effect may be beneficial in some women. Okay, surgery modified vestibulolectomy may be considered in cases where other measures have been unsuccessful, and patients who have responded to topical lidocaine prior to sex have a better outcome. Okay. So the woman who you gave her lidocaine and she get better, she will be most likely benefit from the surgery. Okay, and it is most likely it is this modified vestibulorectomy considered in case where other measures have been unsuccessful. Just let the azan to finish. Sorry, 5 minutes. Okay, so regarding the follow-up, it is as clinically required, and the long-term follow-up and psychological support may be needed, and patients should be given a full explanation of their condition with written information. So for the unprovoked vulvodynia, the etiology is unknown. This is the second one. Okay, and the condition is best managed as a chronic pain syndrome. This unprovoked vulvodynia means that there is no any irritant or there is no any stimulant for this pain. So symptoms, pain that is long standing and unexplained, and may be associated with urinary symptoms such as interstitial cystitis. Okay, so if take care, if they bring for you what of the condition that it's associated with, it is the interstitial cystitis. The vulva appears normal, complication sexual dysfunction and psychological morbidity, and the clinical diagnosis is made on history and examination having excluded other causes. Okay, so this most likely, this is because it have no there is no exactly there is a cause stimulant or these things. So most likely this will be need psychological support this patient. Okay, so the management and further investigation after exclusion of other treatable cause, no further investigation is required, and the treatment will be MDT with approach to patient care, and that combining treatment can be helpful in dealing with different aspects of the vulval pain. And the treatment resistant unprovoked may require referral to pain clinic. So pain management. Okay, pain management. The first one, just it is lidocaine and avoiding irritation and these things. But here there is element of psychological, there is element of psychological problem, and also because it's unprovoked, this patient may need pain clinic. Okay, the recommended regimen is that use of emollient substitute, as we said, as pain modifier, tricyclic antidepressant, because of the element of the there is depressive element are well established in chronic pain management, and few studies have specifically examined the effect in vulvodynia. However, amitriptyline is frequently first line treatment. Amitriptyline is the first line treatment, and those should be increased by small increments starting at 10 to 100 daily according to patient response. If unresponsive or unable to tolerate the side effect, you will go for the gabapentin or pregabalin. Okay, is it clear till now? For the alternative, the topical local anesthetist, for example, 5% lidocaine ointment or 2% lidocaine gel, a trial of local anesthetist may be considered, although irritation is a common side effect, the cognitive behavioral therapy and the psychotherapy. My voice is clear?
Yes, it's clear.
It's clear.
Yes. Yeah. ايوه بعد شويه. Hello, yes. So cognitive behavioral therapy and psychotherapy, this is very important. Okay, just I will go and then we will go back. And acupuncture, don't forget, and the follow-up. The follow-up is as clinically required, and patients should be given a full explanation of their condition with written information. Okay, just I want you to revise this again. Sorry, because this is area of exam. I want you to be, yeah. So for the So for the vestibulodynia, localized provoked vulvodynia, which we call, and the other name is vestibulodynia. Take care. Localized provoked vulvodynia, vestibulodynia. What is the management of it? Okay, it is most likely the treatment will be MDT approach, avoiding irritation, emollient substitute, local anesthetist على طول. First things is a 5% lidocaine ointment or 2% lidocaine gel. Okay, applied to 15 to 20 minutes prior to sex. Okay, and then the third one is that physical therapy. This is the third line. Pelvic floor muscle biofeedback, vaginal transcondense, vaginal trainer, and cognitive behavioral therapy. This is for what? For the local
provoked
vulvodynia. The other name, what is it?
Vestibulodynia.
Yeah, exactly. For the alternative, we will go for pain modifier like amitriptyline, okay, or gabapentin, antidepressant, and gabapentin and pregabalin, or surgery. Don't forget the amitriptyline dose, 10 to 100. Okay, surgery modified vestibulectomy, and then the follow-up. My voice is clear or not clear?
Clear, ma'am.
Yes.
Yeah. For the unprovoked vulvodynia, what is it? We said that it is the same, and the cause is not seen. Okay. Refer to pain clinic, MDT approach. Then you'll go for pain clinic for the resistant unprovoked, especially. Okay. You will go for emollient substitute, pain modifier, tricyclic antidepressant, don't forget. And then the amitriptyline. If no response, you will go for gabapentin or pregabalin. And the alternative, as we said, you see, the local anesthesia is the last thing here. Take care. There was the local anesthesia, the first thing, local anesthesia. Here's the last thing, local anesthesia. Okay? Take care. So local anesthesia, cognitive behavioral therapy and psychotherapy, and acupuncture.
It isn't included in the pain management. Sorry.
Hmm?
I'm sorry, Dr. Rasha. I mean,
Yes.
the first line was the pain management.
No, because this lidocaine, it can be applied, prescribed by the GP. Okay? So this is no, it is not by the pain management. Pain management is another issue, another medication. Okay? Specialized, specialized. Because you are at the level of the ST5, you are not special, you are not the one who will decide for these things. Okay? Just take the simple things. That's lidocaine, because it can be even by the GP. So it will not be by the same pain management, because the pain management is a specialty. Okay?
Okay.
Yeah. Then the extra mammary Paget disease of the vulva. Extra mammary Paget disease of the vulva, which is incidence is rare, seen most likely in postmenopausal women. Vulvar pruritus and pain and eczematous sweeping. Diagnosis is confirmed by biopsy. It can affect the apocrine gland of the vulva. It has two types. The primary form begins as intraepithelial lesion. Secondary form is due to invasion from an underlying adenocarcinoma, which may be anorectal, urethral, or genital tract carcinoma, endocervical, or endometrial. Take care. Adenocarcinoma with Paget disease. Okay? One of in the scenario, if you found adenocarcinoma, you will go immediately for Paget disease of the vulva. Is it clear? So you have primary form, which is intraepithelial lesion, and the secondary form, which is adenocarcinoma, which may be anorectal, urethral, or genital tract carcinoma. And it is most seen in the postmenopausal, and there is vulvar pruritus and pain, and eczematous sweeping lesion. confirmed by biopsy, affect apocrine gland of the vulva. Okay? Just I want you to concentrate just on the main things. That adenocarcinoma, post-menopausal, okay? And that is confirmed by biopsy. That's it, the most important thing in this slide. Okay? The extra mammary, so you have extra mammary and mammary. So the extra mammary disease can be associated with an underlying adenocarcinoma, the GIT and urinary tract, and the breast should be checked also, because it can be with the adenocarcinoma of the breast. Take care. Okay, surgical excision is recommended and recommended to exclude adenocarcinoma of the skin appendage. Photodynamic therapy and topical imiquimod have been used with some success. Okay, despite obvious clinical feature, surgical margin are difficult to achieve owing to subclinical disease and recurrence is common in this type of the vulval lesion. Okay. Just the most important thing is that there is extra mammary budget disease. You just in the scenario it can help you in the diagnosis. Okay, the surgical excision is recommended to exclude adenocarcinoma of the skin by appendage. Okay, because it is associated with adenocarcinoma. So the management of it, any cancer, we should remove it. So surgical excision. That's all of it. Okay, don't go deep now. Enough this. For the treatment, wide local excision, okay, margin often extended for far beyond, which is what is visible, macroscopically high recurrence, and the current move to perform less radical resection for intraepithelial lesion with a re-excision at a later date should lesion recur. So lesion on anus and urethra require laser therapy. This is from the FIGO. I bring this, okay? So the treatment is wide local excision, current move to perform radical resection, but there is a high risk of recurrence. Okay, lesion on anus and urethra require laser therapy. Conservative therapy like imiquimod. According to the Cochrane meta-analysis, there is no best intervention for vulvar budget disease, and if underlying adenocarcinoma is present, radical wide excision with 1 cm margin plus adjuvant radiotherapy like squamous cell cancer. Okay, so take care. If they said to you in the scenario that the patient, they did for her a biopsy and the adenocarcinoma was evidence, so you need to do radical wide excision with 1 cm margin plus adjuvant radiotherapy like squamous cell cancer. Okay. The best disease, this is chronic multisystem disease characterized by recurrent painful oral and genital ulcer. Oral and genital ulcer. This is in the scenario came like this. Best disease, oral and genital ulcer. Okay. Ulcer involves the cervix, vulva, and vagina or vagina, and the ulcer are usually recurrent and painful and can leave scarring. Treatment to control flare-up and reduce symptoms is based on topical or systemic immunosuppression. So it needs systemic immunosuppression. And the basic disease is a rare autoimmune-mediated systemic vasculitis that present with oral abscess ulcer, painful genital ulceration around the anus, vulva, or scrotum, and erythema, nodosum, and ovitis. Just know that we have oral or genital ulcers. This is all things. Her management is immunosuppression, and it is rare autoimmune disease. Okay. Vulval candidiasis tend to present with irritation and soreness of the vulva, and it is most likely in diabetic woman. Obesity, antibiotics may be contributory, may become chronic and leading edge of inflammation with satellite lesion extending out from the labia majora to the inner thigh or monos pubis, and the prolonged topical antifungal therapy may be necessary to clear a skin infection with oral or topical preparation. For the plasma cell, vulvitis. This is a rare benign chronic inflammatory condition of the vulva, present with symptoms of pruritus, burning, and dyspareunia. Usually present is the postmenopausal women, like what now we mentioned. One of the cases that it is more common in postmenopausal. Anyone can tell me? Paget disease. Yeah. Okay. It is diagnosed histologically and is characterized by dermal infiltration with plasma cell, vessels dilatation, and hemosiderin deposition. So take care. In the exam question, in the scenario, there is plasma cell. There is plasma cell. Okay. There is vessel dilatation. There is hemosiderin deposition. Hemosiderin. Okay. So all this, it comes with plasma cell or vulvitis. The etiology is unknown. One theory is that it is an autoimmune disorder, and there have been case reports favoring successful treatment with topical ultra-potent steroids. So the management of it is ultra-potent steroid. So put it in the side of the Lichen sclerosis and these things. Okay? Is it clear? In this slide, you should just know that it is benign chronic inflammatory, diagnosed by histologically by plasma cell vessels dilatation and hemosiderin, common in postmenopausal. Okay, and it is an autoimmune also. Treatment is an ultra-potent steroid. For the Crohn's disease, is chronic inflammatory bowel disease, can involve the vulva by direct extension from involved bowel or metastatic granuloma. Rarely it is seen without known bowel disease or preceding the presentation of bowel disease. The vulva is often swollen and edematous with granuloma, abscess, draining sinuses, and ulceration. This is Crohn's disease. So it means that there is ulcer, abscess, granuloma, these things. So just put in your mind this. Okay? My voice is clear?
Yes.
Yes, yes.
Yeah. So surgery can result in sinus and fistula formation and tissue breakdown, and therefore should be avoided. Treatment include metronidazole and oral immunomodulator. This is the treatment of Crohn's disease. Surgery is avoided because of sinus and fistula formation. Metronidazole and oral immunomodulator is the treatment of the vulval Crohn's disease. So if they said to you that you have a GIT problem, or they have GIT, for example, disease or whatever, bowel or any granuloma, you should put in your mind this is Crohn's disease. That's it. This is the key for this Crohn's disease. Okay. ما خلصنا ونحن لسه الناس دي. Okay.
ربنا يجزيك
Okay. Okay, inshallah, all of you will succeed. So now we will begin the vulval cancer. I don't know if you want to take a coffee or anything, because we have a question after it. Many questions. Actually, I did this and I did vulval cancer, and then there is question, EMQ and question, and then I put the and then I put the cervical cancer and the endometrial cancer. I think today you cannot do all this. I think so. So if you, I don't know when to do it, wallahi, I don't know, but yani, if you have a time, or even at any time, for example, morning or whatever, we can do it if you'd like to do it. Yani.
Tomorrow, Doctora.
Tomorrow, wallahi, but just I have a duty at morning, but it can be after tomorrow, no problem. After tomorrow morning, I don't have things. I am 16 actually. I am 16 hours after tomorrow. If you can do it morning at 9 or 10 a.m. morning, and for me, no problem.
Because very important. Very important topics.
Yeah, actually. Wallahi, I did it very well. I want to do it for you, but I don't know if you have a time, because now your time is very limited, and I know you have very limited time.
We are wasting our time, Dr. Rasha. Thank you very much for making it easy. We will attend. If you organize the time, we have to come.
So just Yes, thank you, Dr. Khalid. So I think better for me because tomorrow really I'm duty at morning, but after tomorrow I'm 16 hours from 4 p.m. So if I do it from 9 a.m., no problem for me. It
Dr.
is
Rasha,
already ready. Yani.
whenever you will do, please
afternoon?
just do recording, na? So that at least those who cannot attend because of the duties, they will do later on.
Yeah, of course there will be a recording. That's for sure. Okay. Yeah.
Thank you very
So
much.
just
Thank
you
you
are
very
welcome. So
much.
5 minutes, just bring a coffee or any tea or anything so that you can complete. Okay.
Okay.
Thank you.
Excuse me, where can I find the older recordings?
Audio recording of these sessions or what, Dr. Amai?
Sorry, I know that you've done all other sessions that I missed. So where can I find the recordings, please?
You can find them in Dr. Ghada recall group or in Dr. Rasha secret group as well. In Telegram group.
In the Telegram group.
Yeah. Telegram group. Either Dr. Ghada or Dr. Rasha as well. Yeah.
Thank you.
You're welcome.
Excuse me, is it the same group that is the MRCOG Part 2 discussion on Telegram?
No, it is another group called MRCG Secret or Recall, MRCG Recall. It is Dr. Ghada Badran group.
Hello? Yes, I think let's complete.
Unmute.
Yeah, so vulval cancer Vigo 2018. Yeah. He said that vulval cancer is uncommon and accounting for only 2 to 5% of gynecological malignancy. Okay? The squamous cell carcinoma of the vulva is the most common subtype. Is it clear? So the most common is the squamous cell carcinoma, and the vulval cancer as overall account for 2 to 5% of the gynecological malignancy. Regarding the prevention, we have primary prevention, secondary prevention, and tertiary prevention. For the primary one is that as for cervical pre-malignant lesion predisposing to cervical cancer, persistent human papillomavirus infection, particularly by the human papillomavirus 16 subtype. Okay, so vaccination means that vaccination. Okay, for the secondary prevention is that by screening. There is no evidence for specific screening for vulval cancer. Self-examination in women with Lichen sclerosis, a condition related to vulval cancer development, should be encouraged. So that, as we said before, in case of Lichen sclerosis, we should ask the patient or tell her about you will give her patient information leaflet, and you will tell her that there is a red flag. If you have any lump or you have any change in the area, you come to be investigated because there is any hidden or there is any sinister issue. Okay, for the tertiary, my voice is clear?
Yes, it
Hello?
is clear.
Yeah, for the tertiary prevention,
clear.
yeah, it is management of the pre-malignant lesion. For the tertiary, it is as a management of pre-malignant lesion, like VIN. Okay. Okay, so there are two main pathological pathways that lead to vulval squamous cell cancer, either by keratinizing. Squamous cell cancer usually occurs in the older woman, and is often associated with Lichen sclerosis and Lichen or differentiated type. Okay, and the warty bacilloid squamous cell cancer generally occur in younger women and is caused by persistent infection with oncogenic strain. Yeah, exactly, human papillomavirus. Particularly 16, 18, 31, and 33. 16, 18, 31, and 33. Okay? Not 3 and 1 here. No, 31 and 33. Okay? Yeah, this is the FIGO staging for the carcinoma of the vulva. Just I want you to anyone he can just for as a revision for you. Anyone can say it. Who will enter the
Stage
exam.
1.
Yeah. Yes.
Stage 1 is tumor confined to the vulva. Again, further divided into 1A and 1B. In 1A, lesions less than or equal to 2 centimeter in size, confined to the vulva or perineum with stromal invasion of less than or equal to 1 millimeter square, and there is no nodal metastasis. 1B is lesions more than 2 centimeter in size or with stromal invasion more than 1 millimeter square, confined to the vulva or perineum with negative nodes. So basically, stage 1 is negative nodes. And stage 2, tumor of any size.
Just 1 minute. Negative node, and just it is confined to the vulva, just in the vulva. Okay. Yeah.
Stage 2 is tumor of any size with extension to adjacent perineal structures like lower 1/3 of urethra, lower third of vagina and anus, and again with negative nodes. So stage 2 is regional spread with negative nodes. Moving on to stage 3, it is tumor of any size with or without extension to adjacent perineal structures, that is with or without spread to lower third of urethra, lower third of vagina or anus with positive inguinofemoral nodes. Again, further divided into 3A, 3B and 3C. 3A has 1 and 2 with 1 lymph node more than or equal to 5 mm, with 1 to 2 lymph nodes less than 5 mm metastasis. In 2B, 2 or more lymph node metastasis of more than or equal to 5 mm, 3 or more lymph node metastasis of less than 5 mm. Whereas in 3C, it is positive nodes with extracapsular spread. And in stage 4, tumor invades the other regional
So if they said
areas.
that if extra capsular spread means that 3C. Take care. Positive node and extra capsular spread, it is 3C. If there is involvement of the lymph node, it will be stage 3, definitely. Okay?
Yes. Stage 4 is tumor invades the other regional structures like upper two-thirds of the urethra, upper two-thirds of the vagina, and distant structures. So 4A will be tumor invading the upper urethra, vaginal mucosa, bladder mucosa, rectal mucosa, or fixed to pelvic bone. And 4A also includes fixed or ulcerated inguinofemoral lymph nodes. And 4B is any distant metastasis, including the pelvic lymph nodes.
Yeah. Okay. The depth of the invasion is defined as a measurement of the tumor from the epithelial stromal junction of the adjacent most superficial dermal papillae to the deepest point of invasion. Okay. So this is the FIGO staging of the carcinoma of the vulva. This is as per the algorithm for the gynae. Okay, this is stage 1A, as you see, and this is for the 1B. This is for the anyone can tell it from his mind without seeing the
1A is less than or equal to 1 millimeter and less than or equal to 2 centimeters. And 1B is depth more than 1 millimeter and extension more than 2 centimeters.
Yeah, excellent. Okay.
Stage 2 is and in stage 1 there are no nodes.
Yeah, exactly. Yeah, in 1 and
stage
2 no nodes.
Stage 2 also there are no nodes, but it involves the regional structures like lower 1/3 of the urethra, lower 1/3 of the vagina, and anus.
Yeah, exactly.
Again without nodes. Whereas in stage 3, it can be of any size, it can be anywhere, but involvement of nodes will be there.
Yeah.
In 3A, we have one node, one lymph node more than 5 mm, or 1 to 2 lymph nodes less than 5 mm.
Yeah, exactly.
In 3B, we have we have 2 lymph nodes more than 5 mm, or 2 to 3 lymph nodes less than 5 mm.
Less than. Exactly. With?
In 3C, we have extra capsular spread of that lymph node.
Yeah. Yeah.
In 4A, we have like spread to the distant structures like upper urethra, upper two-thirds of the urethra, upper two-thirds of the vagina, and then also it will be fixed to the pelvic structure, pelvic bone.
Yeah,
and then it also involves the ulcerated fixed pelvic nodes in 4A. Whereas in 4B, it is distant metastasis to the liver parenchyma or to any other distant sites.
Yeah, exactly. So this is excellent. So this is for the, just take a screenshot because it will be easy for you to memorize it. Okay, I put it for you just to remember it.
Can we go to the previous slide, please?
What you said? I didn't.
I'm asking, can we go to the previous slide, please?
Previous. Okay. This is the previous.
So I'm confused about stage 4.
So invade the regional upper 2/3 of the urethra to upper 2/3 of the vagina and 2/3 or distant structure. And 4A,
so what's the
most
difference
likely
between 4A and B? What's the difference between 4A and 4B? Sorry.
This is for distant metastasis, distance. As we see, as you saw here in the picture, it is distant, not in the pelvic area alone. It is distant in the liver, for example, as you see here. Okay? This is just for the pelvis, confined to the pelvis.
So it is regardless of what's in the pelvis,
regardless
basically.
of size, regardless of anything. Yeah, exactly. Okay, and also one important thing is that here there is in the 4A there is ulcerated or fixed inguinofemoral lymph node, because in the scenario question most likely they mention this. So put in your mind that if there is inguinofemoral lymph, means that it is 4A. Okay. Extra capsular spread, it is 3C. Okay. Take care. from this.
Thank you.
Yeah. So treatment. The treatment depends primarily on histology and staging and diagnosis. So diagnosis first, any suspicious vulvar lesion should be biopsy to exclude invasion. بعدين خلاص. So any suspicious vulvar lesion should be biopsy to exclude invasion, and this can be done under local anesthetist with anesthesia, with a 3 to 4 or 4 Kais biopsy, okay, instrument, or with an incisional or wedge biopsy. If the diameter of the lesion is 2 cm or less, and the depth of the stromal invasion is less than or equal to 1 millimeter on the initial biopsy, it is usual to do a radical wide local excision, okay, of the lesion to assess the maximum depth of the invasion. Okay, are you with me, or you fall down from? Okay. Okay. So, as we said, if the diameter of the lesion is 2 cm or less, and the depth of the stroma invasion is less than or equal to 1 on the initial biopsy, it is usually to do a radical wide local excision of the lesion to assess the maximum depth of the invasion. If no part of the lesion has a depth of the invasion greater than 1, then the excision is adequate definitive treatment. And we will talk now specifically about each stage. Just this is for us to understand. Okay, so the investigation he will do for this woman, for this patient, cervical pulse cytology and colposcopy of the cervix and vagina, full blood count, biochemical profile, liver profile, HIV testing, and chest X-ray. CT or MRI scan of the pelvis and groin may be helpful, especially for locally in advanced tumor to detect any enlarged lymph node in the groin or the pelvis. 18 fluorodeoxyglucose post-run emission tomography with computed tomography scan can be more effectively assess and detect inguinofemoral lymph node. Okay, involvement compared with the CT alone. So the PET, which is post-run emission tomography with computed tomography, it is more effective in detecting the inguinofemoral lymph node in comparison with the CT alone. All women who have stage 1B or stage 2 cancer should have an inguinofemoral lymphadenectomy. Okay, 1B or stage 2. Less than 1% of the patients who have small lateral lesion, less than 4 cm and more or equal to 2 cm from the vulvar midline, and a negative ipsilateral node have metastasis in the contralateral groin node, and therefore an ipsilateral groin dissection is adequate treatment for this patient. Okay, is it clear till now?
Yes, ma'am.
Okay, so patient who have tumor closer to for example less than 2 cm or crossing the midline, this involve, for example, the anterior labia minora, and those women who have very large lateral tumor more than 4 cm or positive ipsilateral node should have a bilateral groin node dissection. Okay, For the advanced vulval cancer, including the tumor that extended beyond the vulva and or where there are bulky positive groin node, the management of women with advanced vulvar cancer is complex and should be individualized and carried out by MDT. And if there are no suspicious node, either clinically or on imaging, bilateral inguinofemoral lymphadenectomy may be performed. And if the nodes are negative, radiotherapy to the groin and pelvic node will not be necessary.
I will not go. Why? Because my driver take 1 hour to come from there. So if they know me, they should tell me before.
Okay, so however, if the histology reveal positive node, then adjuvant radiation to the groin and pelvis should be offered as for early stage disease. So if, for example, you have advanced vulval cancer and there are no suspicious node, either clinically or by imaging, so bilateral inguinofemoral lymphadenectomy may be performed. And if the nodes are negative, radiotherapy to the groin at that time will not be necessary. Okay, if the node after you did bilateral inguinofemoral, because already this is advanced vulvar cancer, you use, if there is no suspicious, either clinically or on imaging, you will do bilateral inguinofemoral. It is for lymphadenectomy. No way you will do lymphadenectomy. If the nodes are negative, radiotherapy is not necessary. Okay. However, if histology reveal positive node, then at that time this patient should then adjuvant radiation to the groin should be offered as for early stage disease. لازم should be done at this time. Okay, for that. Surgical excision of the primary tumor with clear surgical margin and without sphincter damage, whatever possible, constitute the optimum way to treat advanced vulvar cancer, as well as to palliate symptoms such as local pain and offensive discharge. Okay? So chemoradiation, neoadjuvant treatment with cisplatin and 5-fluorouracil or other chemotherapy combination has been reported to be effective. Okay? For preservation of the anal sphincter and or urethra in patients with advanced vulvar cancer. This is the 5-year survival rate. Okay. As you see here, it is most likely 70 something, 79 or something. In the stage 2 here, it is 60. Here it is like 40 or like 43 or 44. And for stage 4, it is like 8, 9, 15 or 16. Okay. This for stage 4.
Ma'am, this is from FIGO 2018, the 5-year survivals.
No, this is not for the FIGO. I will show you now because it is written another things, but most likely what I want to tell you is that better to go for the strategy percentage. Okay, better to go with them because this is their source for this thing. But most likely, I found that this percentage, they bring it from the Cancer Research Center in the UK. This paper. Okay.
Yeah.
أطلع.
Yeah, mom.
Okay, so this is what I understand is that this is the newest one. This one for this gynae algorithm, but because it is from the cancer center. But for me, I put the slide for all from the strategy. It is the same. Okay, there's a little bit difference, but for me better to go with the strategy percentage. Okay.
Okay, ma'am.
Yeah, I will show it inshallah actually. This is the tips to solve question. Just I put it like a tips for you. In women with Lichen sclerosis, there is autoimmune disease, 30% in first degree relative, circulating antibody around this, I mean circulating antibody and demarcated glass erythema is around introitus, frequent in the erosive Lichen planus. Take care in the erosive type. Okay, if biopsy site requires suture, yeah, an undyed vicryl suture should be used. This is all these line are area of question. Okay, so undyed vicryl suture used for if you do a biopsy and you need a suture to be done after you take the biopsy. Undyed vicryl suture. Okay, the Lichen sclerosis at any age, but commonly the postmenopausal. The Lichen planus usually affects mucosal surfaces more commonly in the oral mucosa. The Paget disease is associated with adenocarcinoma. This is all key point. Okay, take care and take a screenshot from this. The lichenification is found in eczema, Lichen sclerosis, Lichen simplex, and Paget disease. Okay. For the EMQ, actually this is one papers I think with Dr. Mustafa, I think put this before, just I put it for you because this is very important, especially in these days, and each line is an EMQ. Each line of this is an EMQ. Okay, so just let's start. The woman, for example, if he brings for you woman with at any age but usually more than 40 years plus vulval irritation plus labial fusion plus skin atrophy, this is you will go for a steroid, which means this is Lichen sclerosis. If you have large vulval lesion more than 4 cm plus suspected Lichen lymph node, you will go for radical valvectomy plus in-block groin lymph node. Okay, so that to remove the tissue between the vulva and the involved node. Okay, in block, like a block, yani you will take it like block. The vulval basal cell cancer, by the management of it is by wide local excision, no lymph node, no lymph node, because as I remember, it is not transfer or not transfer or go with lymph node. So no need to remove the lymph node. Okay, for the vulval verrucous tumor, this is wide local excision and also no lymph node. For the vulval melanoma, wide local excision and no lymph node. For the lateral lesion plus less than 2 cm plus invasion less than 1 millimeter, you will go for wide local excision and no lymph node. I hope it will be helpful for you, really. And for medial lesion plus more than 2 cm plus invasion more than 1 millimeter, you will go for triple incision. Okay.
Yeah, but lateral lesion more than 4 centimeter also we go for lymphadenectomy.
Yeah, more than 4. Yeah, here. Yeah, for lymph node. Yeah, exactly. Okay. Yeah, and this also here lateral lesion plus more than 2 cm plus invasion more than 1 millimeter. This is wide local excision plus ipsilateral lymph node. Okay. For tumor more than 2 cm plus close to the vital organ like urethra, like anus, like this, plus more than 1 millimeter invasion, you will go for multimodal therapy. It includes radiotherapy to reduce size first, then surgery. The VIN by wide local excision, as we mentioned, pain in the vulva plus raised purplish flake and fine white reticular pattern, which is Wickham's striae, plus mouth ulcer. This is most likely with Lichen planus, because one of the recall question. Okay, Wickham's striae and white reticular pattern. Okay, mouth ulcer. The vulval cancer is staged by surgical-pathological staging, and I have one paper, just I put it for you to be easy for you. It is like the word you are, for example, you are staging the UO, it is assigned for the ovarian, and for U is assigned for the uterine. So it is the vulval cancer is staged by surgical pathologically. Okay. For the postmenopausal, perimenopause plus recurrent Bartholin abscess, this is where you will take biopsy to exclude cancer. For the Bartholin gland cancer, you will go for wide resection plus partial resection of the anal sphincter and repair plus defunctioning colostomy plus bilateral dissection of the inguinofemoral lymph node. Okay. This is for the strategy. Just make. I think it is there. All of you have it. Also, try to revise it. Okay. And if you have, for example, in the question, if he mentioned to you any difference between this, because this is from strategy, and you found another percentage, go with the one which I put it from the cancer center. Okay, from UK. Okay. Okay. So time for the EMQ and SBA. Okay, so who will go start with the question? Now, how many hours we spend?
I will do, ma'am.
You are now. You can do it, or we can leave it for another time, because maybe others are now.
Okay, ma'am. No, we'll just go ahead with the class.
Okay. So. This is the EMQ, and this is the question. Read the question. $3 hours. So you want to do it on after tomorrow? I don't have any problem.
We'll finish the questions, ma'am. We'll finish the questions.
Just 1 minute. Sorry. So I want to change this. Sorry, just it will disappear the screen. Just 1 minute. Okay. Sorry, just 1 minute. Extract. Just 1 minute. So where is Dr. Asif? Is there Dr. Asif or not here? Okay. So that we will change the time to next. Next after tomorrow morning, 9 a.m. It is good for you, or 10 a.m. I mean, KSA time. We will do now the question, but just I'm asking, is it okay 10 a.m.? for all of you?
9 a.m. is good, ma'am. 9 a.m. is good.
Otherwise, can you do it on Wednesday, ma'am?
10. I don't know, maybe 10. I will see, okay? No problem. Just 1 minute. Yes. Okay.
Is that 9 a.m. UK time or Egypt time?
Egypt time. Yeah. It will be less KSA. I mean, Egypt, it will be, I think, 9. If it is 10 a.m. in KSA, it will be 9 a.m. in.
So what time KSA, please?
KSA, it will be 10 a.m. Okay. Sorry. Yeah, this question. Okay. Okay. So, yes. Okay, this is the question. Okay, read the question. Yes. Is it clear in the? It is about 30, I think 30 something question. If you can, you want to do it today, I can do it. If you don't want, you can do it with the both topic for the endometrial cancer and cervical cancer on after tomorrow, if it is good for you, or at least we will go for 15 questions. Okay.
Let's do a few today.
Yeah, let's do a few. Yeah. Okay, so who will do this? Let's do.
Okay, shall I read it? A 73-year-old woman is seen by the GP for routine recall of her lichen sclerosis. She mentioned that the itching has become gradually worse over the year with no relief after using different creams suggested by the pharmacist. She also mentioned she has some swelling down below that feels like a size of a 10-pence coin. She's referred to the hospital, and on examination, a biopsy is taken under local anesthetic in the clinic pre-op. So what to do for her?
What you will do for her? What you will do?
A wedge biopsy. We'll take a wedge biopsy of the lesion.
She is this patient. This patient. Sorry. This patient. What's her in the question that now pre-op. What to do for her pre-op? She will go to do refer to the hospital and examination, and a biopsy is taken under local. So what to do?
Okay. Can I see the options, ma'am?
Yeah.
H, ma'am.
Exactly.
H. We don't need CT pelvis, ma'am. CT pelvis not required.
Not required. No.
Okay. Biopsy
should be H. Yeah.
Should be refer.
Should be what?
Refer.
Refer? No. He's asking about the pre-op investigation. What you will do for her? Okay. So what you will do for her? Full blood count, serum biochemistry, chest X-ray, and ECG, because this patient 73 years old.
More than
63. Am I right? Yeah, she's 73. 73, I mean. 73 years old woman. Is it clear for you? Yeah, it is.
But we have not ruled out lymph nodes at all. Lymph nodes, there's nothing given in the history, and even in the examination, we are not doing anything to look
no, but
for the
he
lymph
didn't
nodes.
ask. He didn't ask about what you will do.
Yeah.
He asked about pre-op. What you will do investigation for her. That's the question.
No, that's what I was thinking, like whether CT pelvis is required, because we don't know anything about the lymph nodes at all.
Yeah, you are right. Yeah, exactly.
Size is less than 1 centimeter.
Yes, size is less than 1, so we don't need CT.
Yes.
Yeah, because the risk of lymph is less than 1%. Okay, so this is the answer.
Then 1.
Okay, this is the answer. Second question.
I can try, ma'am. Second. A 72-year-old woman is seen in a urogynecology clinic complaining of pelvic organ prolapse. Of note, there is a history of intermittent steroid cream used for a sore and itching vulva. On examination, there is a warty lesion on the vulva that is near about 1 into 1 centimeter on the left inferior aspect of labia majora. There is a warty lesion, 1 to 1 centimeter. I'll go for a biopsy. Yes, ma'am. Can I see the options, ma'am? I'll go for wedge biopsy. Refer to the dedicated gynae oncology vulva clinic for an opinion. Yeah, I can do that. Unilateral inguinofemoral, no. Without biopsy, we will not do any kind of surgery. Unilateral left inguinofemoral lymphadenectomy is recommended. No. Arrange excision biopsy of the entire lesion under local anesthesia. No. Entire lesion is wrong. Bilateral inguinofemoral lymphadenectomy. No. FBC, serum biochemistry, chest X-ray, ECG, CT, pelvis. First, we have to do biopsy and then we have to go for another investigation. Prescribe topical imiquimod. No. FBC, serum biochemistry, chest X-ray, ECG. No. Wedge biopsy of the lesion. Yes. FBC, serum biopsy. Ma'am, I'll go with I. Wedge biopsy. Because I was looking for this option.
Which biopsy? But this patient, you have the warty lesion. You suspect cancer in this patient. Am I right?
Yes, ma'am.
So need to be referred to dedicated gynae oncology vulval clinic.
But ma'am, we should do a biopsy first because it's not a high suspicion of cancer. If like there's an irregular growth.
No, because she had a history of intermittent steroid cream used for sore and itching vulva and no benefit. And now she gets warty lesion. So this is risky for cancer and her age also. This is most likely to be a cancer. Yeah, because a history of what? A history of intermittent steroid cream used for a sore and itching vulva. So means that maybe this is Lasher sclerosis developed to go for warty, most likely VIN will go for cancer.
Okay, ma'am. Basically, I was like, yes, ma'am.
Yeah, the answer is A, actually. Okay, this is the answer. This is from study, okay? Question. We'll go for next. Thank you, Doctora. Who's with me?
Thank you, ma'am.
Thank you so much. Who will go for the other?
Ma'am, shall I do? Dr. Ramya. Question, ma'am. A 70-year-old woman presents via an urgent referral with a 4-month history of vulval pain. On examination, she has a 4 centimeter irregular exophytic tumor replacing the clitoris and extending within 15 mm of the urethra. Enlarged 1 lymph nodes are palpable in both groins. Ma'am, options? Ma'am, we should refer to the gynec oncology clinic, ma'am.
No. Why? Why no? Because the question here, he said to you that this patient present to you with an urgent referral. Means that the GB refer to this oncology gynae clinic. Okay?
Okay, ma'am.
Yeah, this is the previous question. Okay?
So it needs Bilateral
Yeah.
inguinofemoral lymphadenectomy is recommended, ma'am.
This is most likely wedge biopsy first. We will see what is this. Wedge biopsy first.
Wedge biopsy, okay, ma'am.
Yeah.
So pre-op, we
So
should
take
do
care
biopsy.
in the
Pre-operatively, we should confirm the lesion by wedge biopsy, ma'am.
Yeah.
Okay.
Exactly. You should first confirm it, and also what it is from the history, and from the scenario that the patient present with you with urgent referral, with a 4 months in story of vulval pain. Okay, so means that you will take action now.
Okay, ma'am.
Yeah. So this is the wedge biopsy is the answer of the lesion. Okay.
Okay, ma'am.
Next question.
Can I go,
You
please?
can read. Yeah, of course.
60 years old woman at the vulva clinic. She initially presented 2 weeks ago complaining of soreness and irritation of the vulva. On examination, there was 4.5 centimeter ulcerated lesions on the left anterior vulva involving the clitoris. A bunch biopsy was taken, and the histology reveals squamous cell carcinoma. In addition to radical excision of the primary lesion, how will you counsel her regarding the lymph node management? So for this patient, it's more than 4 centimeter. I will counsel her for bilateral lymph node lymphadenectomy.
Yes. So what is the option? Which option you mean?
It's E, bilateral inguinofemoral.
Yeah, excellent. Exactly. It is E. Yeah, exactly. It is obvious. This, as we mentioned before. Okay. This most likely it will go for radical excision plus bilateral inguinal femoral lymphadenectomy is recommended for this patient. Okay. This is the answer. SPA.
Shall I go?
Yeah.
69 years old Egyptian woman presented with a 3-month history of vulval pain. On examination, she has 3.9 centimeter irregular mass replacing the clitoris and extending to within 19 millimeter of the urethra and upper vagina. So it's the lesion went to the upper vagina. That means it's stage 3. Enlarged lymph nodes are palpable in post-growing. What is the next month's appropriate action? Okay. Vulvectomy and bilateral lymphadenectomy, perform CT, scan which biopsy of the lesions, urgent radiotherapy, simple vulvectomy. Extend 90 millimeter of the urethra and upper vagina. But still,
most likely all area. Yeah, all the area.
But it's still not diagnosed. Not diagnosed as a cancer. I have
So
to
we
take
need to do
which biopsy. Yes.
Yeah, wedge biopsy, exactly. Yeah, excellent. So this is the answer. It is wedge biopsy. Okay. As the clinical picture is strongly suggestive of vulval malignancy, a diagnostic biopsy is essential, and a wedge biopsy will provide information regarding the type, grade, and depth of the invasion of the tumor. This information, in combination with imaging and MDT discussion, will facilitate appropriate treatment, and in some cases, for instance, basal cell carcinoma and verrucous carcinoma, lymphadenectomy is not necessary. take care, as we mentioned before, because as we said that the basal and adeno and اللي هي شنو الفيركاس carcinoma not spread by lymph node, as I remember, so no need for lymphadenectomy for them. Okay, so in here we need to diagnose first. Thank you, Dr. Khalid.
You're welcome.
Yeah. We'll go next.
Sorry, this upper vagina is stage 4. Huh?
You should tell me.
4A. Yes, 4A.
4A, ma'am.
Sorry, doctor.
4A.
But just I need you to remember to revise it. So today, inshallah, go and revise this all this. Inshallah, I will put immediately the recording. But just I need you to revise it so it will not go from your mind. Believe me, if you go and revise it again today, at least if you want to go to sleep, just revise it. You will not forget it. Okay. This is the second question.
Excuse me for that question. Won't it be appropriate to do CT because to exclude metastasis because she's stage 4?
Yeah, but first we need to do. What? I didn't understand your question. Sorry.
So because there's extension to the of her vagina, so she is already stage 4. Don't we need to exclude metastasis by CT?
We can do it as he mentioned in the answer, I think. But first, before this, we need to take a biopsy.
We didn't diagnose that it's a cancer or not. We have to diagnose that it's cancer, and then we will go there.
Yes.
So basically, the first step to do is biopsy. Then we follow it by CT and MDT.
By investigation, yes, to see the extent of this cancer and even if there is any other organ involved. Exactly. So the first thing is that to diagnose. Yeah. Okay. So who will go for the question 6?
Ma'am, can I do it?
Yeah.
87-year-old woman is diagnosed with vulval cancer. Clinical examination and imaging showed a mass invades upper urethral and/or vaginal mucosa, bladder mucosa, rectal mucosa, and metastasis to both inguinofemoral and pelvic lymph nodes.
So it would be which stage?
This should be stage of 3.
4B, ma'am. 4B.
4B.
4B. Pelvic lymph nodes is 4B.
Yeah. So this is the answer. Most likely it's correct is H, which is stage 4B. No need to read other. خلاص. Okay. Next.
Regarding vulval cancer, 5-year survival rate for stage 3 is approximately 30%.
40%.
40%, yeah. Exactly. This is 40%. 5-year survival percentage for stage 3 is 40%. Okay. So this is, as I mentioned, this is also strategy, and it is also here. This is stage 3. It is 40% nearly. Okay.
Okay.
What's the most likely diagnosis from the option list above? This is very important EMQ.
55-year-old Egyptian woman presents with dyspareunia, vulval itching, soreness with sometimes constipation, with some skin changes in the form of figure of 8 distribution, including the perianal area. Biopsy is taken from the atrophic areas on the vulva. Histopathology report states there is epidermal atrophy, hyperkeratosis with subepidermal hyalinization of collagen and lichenoid infiltrate. It should be lichen sclerosis, ma'am. Dyspareunia.
Likely, most likely. Yeah, lichen sclerosis, because of figure of 8 and all these things, most likely, yeah, go with lichen sclerosis. Okay, I hear that one. Thank you, my dear. One, he tells that he want to share. Thank you. Who want to share?
Okay, I'll read this. A 25-year-old Egyptian woman, newly married with schizophrenia and is under treatment, presents with vaginal itch and soreness. On examination, there are marked excoriations and lichenification. Most of her pubic hair is absent. So this goes with, I think, lichen simplex.
Yeah.
Pubic hair is absent, and then schizophrenia. Yeah, marked excoriations. All this go for lichen simplex, ma'am.
Lichen simplex, yes. Exactly. Okay.
A 42-year-old Egyptian multiparous woman presents with vaginal soreness, discharge, and dyspareunia. On examination, the mucosal surface of the vagina are eroded. At the edges of the erosions, the epithelium is mauve gray and Wickham striae are noted. It is lichen planus, ma'am. Erosive type.
Yeah.
Erosive type, yes.
Yeah, exactly. So it is lichen planus. Okay. Excellent. Thank you. Who will?
I'll do next, ma'am. A 23-year-old Egyptian woman, newly married, tells you as the clinical registrar, the one area in her labia continuously feels as if it is burning. She finds that massaging that area helps, especially when she uses olive oil. There is no significant past medical history and she is not taking any medications. On examination, the vagina and the vulva appears normal. However, you touch a certain point, this is vestibular dynia. On a certain point on the labia, she jumps up the pain. What is the diagnosis? Hypoactive sexual desire disorder, no. Secondary vaginismus, primary vaginismus, lichen planus. I'll go with E, ma'am, but I'll go with E, vulvodynia.
Yeah, exactly. It's vulvodynia. Exactly. Yeah, because on examination, vagina and vulva appear normal. When you touch a certain point in the labia, he jumps. Yeah, most likely it is vulvodynia.
Ma'am, so can you just clear what is this provoked and unprovoked? This will be provoked or unprovoked?
This is because
and
you.
depression.
It is provoked.
There is in the absence of.
It is provoked because you on touch. When you touch, it has this pain. So this is provoked vulvodynia, vestibulodynia, the first one. Okay. The other one, the unprovoked, most likely it have a sexual, for example, abuse before or something psychological. Okay, but here you have intervention, you have a stimulant. If you touch, there is a pain. So this is most likely provoked vulvodynia, localized provoked vulvodynia. Okay.
Okay.
Ma'am, can you tell a few words about primary vaginismus and secondary vaginismus, ma'am? Ma'am, few points about primary vaginismus and secondary vaginismus.
Primary and secondary is the same. The same. Secondary for يعني for something because, and the primary without cause. It is the same, but another name. Okay.
Primary and secondary vaginismus
means
are
that
same,
because of something.
Both are same, ma'am. B and C options.
What?
What is the difference between B and C, ma'am?
The B, the C, the primary vaginismus means that it is يعني like the unprovoked. But the secondary vaginismus means that there is irritant. Most likely, the woman, for example, she have, for example, episiotomy. Okay, there is a scar area, and there is this. The vaginismus is secondary for this scar formation.
Okay, ma'am. Okay. Okay, ma'am.
For the primary vaginismus, it is something unprovoked, without any cause.
Okay, ma'am.
Most likely go with or abuse.
I seem to recall about vaginismus. The choices are either basically the contractions of the muscle. Are they voluntary, unconscious, or like conscious, involuntary? So which is the right option?
Right option for what? I didn't get you.
So when
For the
they
primary,
so
you mean? Primary and
yeah,
the
yeah. So
secondary?
when for primary vaginismus, when it's the contraction of the muscles, so they say, is it conscious involuntary or unconscious voluntary, something like this, all combinations of voluntary and consciousness in
Yeah,
the answers.
the primary, actually the primary one is that there is tightness in the muscle, okay? And this tightness of the muscle or the contraction of this muscle, there is, in the patient, there will be a fear so that we cannot do sex. This is for the primary vaginismus, okay? Most likely it will be caused by psychological problem.
So is it conscious or unconscious, basically, they're asking? Is it conscious, involuntary contraction of the muscle? That's the question.
What do you mean by conscious? What do you mean by conscious and unconscious? Means
Sorry,
conscious means that because of something. Yeah.
No, she's doing it. She's doing it on her intention, basically.
No,
like she's
it is not
conscious
with
about
intention.
this contraction.
No, it's unconscious. No, unconscious.
So unconscious, involuntary.
Yeah, it's unconscious. Yeah, because there is no anything can do it. This is just most likely because the patient have a history of child abuse or these things for the primary vaginismus. Okay, for the secondary vaginismus, most likely because of episiotomy or there is like this, there is tightness or there is a scar formation in the area. Okay, so that there is a pain with sex.
Ma'am, I have one doubt. Ma'am, in the definition of vulvodynia, the neurological cause has to be excluded. It is given, ma'am. What is the significance of ruling out the neurological cause?
Neurological cause?
Ma'am, in the definition of vulvodynia, it is given that the pain or a burning sensation in the vulvar region without obvious cause after excluding the neurological cause. Now, what is the importance of that?
Neurological cause, maybe there is any problem in her nerves or something like this.
Like herpes, they mean to say,
yeah,
like
because
herpes.
the management will different. The management will different. Okay.
Like nerve
Management will be
entrapment.
another thing. Yeah, but don't go and confuse yourself more. It is just either, as is written in the NICE guideline, either it is provoked or unprovoked. Don't go deep because you will confuse yourself by this. Okay.
Okay, ma'am.
It's the same as written. If it is provoked, go give her lidocaine, the first thing. If it is unprovoked, as you see in the options, go one by one. Okay, don't confuse yourself. And the primary vaginismus and the secondary vaginismus, this is in the third part. There is a scenario station with the primary vaginismus and the secondary vaginismus. Okay, so don't go, yeah. Because in the third part there is a session with what? With that the patient have this episiotomy and then she came with pain. This is the secondary vaginismus.
Ma'am, vulvodynia, vaginismus, that is primary or secondary, these three are different conditions, but ultimately the treatment is same.
Yeah, most likely the treatment is same. Yeah.
Yes, ma'am. Thanks.
Let's go because I think no time. Okay.
Yeah,
so
regarding to the scenario, and vulval intraepithelial lesion, which of these has the highest malignant potential to change into squamous cell carcinoma of the vulva? It's B, BIN associated with HPV 16.
It should be E. It's E. E is the answer. E is the answer.
Lichen
What is E?
sclerosis is 5%. 5% chance.
It's differentiated, DWIN. DWIN has more chance than HPV.
Yeah. So what is the risk of Lichen sclerosis to get cancer?
Less than 5%.
5%, yeah.
Less than
and
5.
how many percentage of the patient with vulval cancer have Lichen sclerosis?
1 to 2%.
1 to 2%.
1%.
I think 25%. I think 20 something. Am I right? 25 or 23%, not 1 to 2%. As I remember. Anyone can confirm for us?
It is
Dr.
up
Rasha's
to
strategy says
5%,
30% of the
3 to 4%.
cancers develop in lichen sclerosis. 30%. It's 30%.
It's 30 to
Yeah,
40%
25
on
to
your notes, you
30%.
said.
يعني more than this, as I remember.
So it is basically 2 to 4% risk of progression to squamous cell carcinoma. But then it says third of the squamous cell carcinoma of the vulva is from lichen sclerosis.
Yeah, exactly. That's what I want. Exactly. Yeah. It is in the books. It is 25, 24, something like this. And in some books also it is 30%. But what I remember it is 23, 24%.
So there's a difference. It says the risk of progression to cancer is up to 5%, basically 2 to 4%. But then when you find people who are diagnosed with squamous cell carcinoma, 30% of those who diagnosed with squamous cell carcinoma had basically this came from lichen sclerosis.
Yeah, yeah, exactly.
But the risk of progression is up to 5%. 2 to 5%.
Yeah. So let's go for the. Thank you. Let's go for this question.
I'll read this, ma'am.
Yeah, just we will continue till 15 and then we will stop. Okay, we are in 30,
okay,
so two questions remaining.
A 58-year-old Egyptian woman.
Yes, sorry, go ahead.
Okay, you read, Khalid.
Thank you very much. Initially presented at Vulval Clinic 3 weeks ago, complaining of soreness and irritation of the vulva. On examination, there was 4.2, an ulcerated lesion on the left anterior vulva involving the clitoris. A bunch biopsy was taken and the histology revealed squamous cell carcinoma. In addition of radical excision of the primary lesion, squamous cell carcinoma of the vulva initially spreads to which group of lymph node? It's inguinal lymph node, E.
E, yes. Excellent. Yes, it's exactly, it is E. Yeah, excellent. Yeah. Next question.
Can you go, Ankita?
Regarding the previous scenario, we will go for the previous scenario. Okay, let's go. This is the previous scenario. So read it, and then you will go to the question.
58-year-old Egyptian woman is initially presented at the vulval clinic 3 weeks ago, complaining of soreness and irritation of the vulva. On examination, there was a 4.2 centimeter ulcerated lesion of the left anterior vulva involving the clitoris. A punch biopsy was taken and the histology reveals a squamous cell carcinoma. In addition to radical excision of the primary lesion, squamous cell carcinoma of the vulva. Ma'am, next question, ma'am.
Yeah, sorry. I want to sleep. Yes.
Regarding to the previous scenario, how will you counsel her regarding lymph node management? Ma'am, it is midline lesion for more than 4 centimeters. So bilateral inguinofemoral lymphadenectomy is recommended because it is a squamous cell carcinoma of the vulva.
Yeah, it is C. C.
Yes, ma'am, C.
Yeah, exactly. It is C. Okay.
Ma'am, when is the sentinel lymph node assessment is done, ma'am? When is what is the indication for sentinel lymph node dissection?
Sentinel lymph node dissection. Complete this the explanation. Mention your
bilateral.
What you mentioned.
Okay, ma'am. Bilateral inguinofemoral lymphadenectomy. The RCOG BGCS guidelines recommends bilateral groin node investigations in lesions within 1 centimeter of midline. Ma'am, actually it is within 2 centimeter of midline, no, ma'am?
Within 2 centimeter, yes. Within 2 centimeter.
That is the FIGO 2018.
Yeah.
As per FIGO, it is within which one to follow, ma'am?
The 2 centimeter, the last one.
Okay, ma'am. Within 2 centimeter of the midline, the diameter of this lesion is above that recommended here. Say 4 centimeter for sentinel node assessment only. The indications for a sentinel node.
But
FIGO
it's sorry, it's
2018 says there is no role for Sentinel node.
Yeah, this is the new one. That's why I want you to read it to revise your information. Okay, here 2 cm and here no Sentinel node now.
Here it
okay?
is 4.2 centimeters, ma'am.
Yeah. The new one, all the new, what they mentioned new.
Ma'am,
Okay.
above 4 centimeter for Sentinel node.
Yeah, above
No,
4.
no role for Sentinel node. In the new guidelines, they say that Sentinel node is still in research and it is not to be practiced. So there is no no role
still,
for Sentinel node at all.
If in the exam came to you, you will do it as written. But in UK, still they do this. Still they are doing Sentinel node assessment.
Yeah, so if less than or equal to 4 centimeters, then Sentinel node is assessed. But according to 2018 FIGO, it is not assessed.
Yeah, exactly. Okay. Okay, so I have another. This is the last one. Yes.
A 39-year-old Egyptian woman, para 4, is referred by her GP with pruritus in the vulval area. She has tried emollients and local steroid creams with no relief. On examination, you noticed redness, excoriation on the vulva. Microscopy of the vulval biopsy reveals areas of spongiosis with acanthosis and parakeratosis. What is the most likely diagnosis? Bullous pemphigoid. A, ma'am.
It is what?
Bullous pemphigoid.
Eczema.
It's eczema.
Because
Eczema.
I think it's eczema.
Yeah, it is eczema.
Okay.
Why it is eczema?
Acanthosis, parakeratosis.
Spongiosis with acanthosis and parakeratosis.
Yeah, all this
and
is
redness, erythematous,
Erythematous and excoriations.
Yeah. Yeah, exactly. Okay. So now, inshallah, when you will do next, as we mentioned, as we said.
Excuse me, I missed question 10. Can we go back just to take a screenshot of? I'll read it. Question
Which
10,
one?
please.
Which one? The question?
10.
10? Just 1 minute. This question 10, yeah. Yes? This question 10. You have any question on it?
Yeah. So can I see just the explanation in the answer? Is it because of weekends?
Yeah, just 1 minute.
Yeah. Thank you very much, Doctor, for all your effort. Jazakallah khair.
Thank you, my dear. You are welcome. So this is the answer. If you want to read it, okay?
Thank you very much, Dr. Rasha. Thank you.
Thank you. Thank you, all of you.
Thank you
Thank
so
you
much.
very much.
After tomorrow.
Thank you so much, ma'am. Thank you.
I hope it will help you, all of you. And I hope that it will be simple for you even, because I know these difficult topics and need to be revised well for the exam, and no exam without them. Okay?
It will be after tomorrow at 10 o'clock?
After tomorrow, inshallah. After tomorrow, I have a morning shift. I am working morning. So that's better for me for after tomorrow at 10 a.m. KSA. Okay? Inshallah.
That's right? 9 Sudan time or...
it will be 9 Cairo and Sudan. Okay?
Okay. Thank you very much.
Dr. Rasha, is that Wednesday? You're talking about the day after tomorrow, right?
Yeah, the day after tomorrow, inshallah. It with this question And also we have the cervical cancer and endometrial cancer. If you have a time for you and for me, no problem, because it is already prepared. These two topics, okay? It's already prepared. Yeah, yeah.
Dr. Rasha, don't forget the video recording, please.
Yeah, today I will send inshallah the recording. Today, just let to upload, and then I will immediately will.
All right. Thank
Okay.
you. Okay, thank you.
So much, all of you. Have a time, inshallah. Have a good time, nice time. Thank you.
Thank you, doctor.
Thank you.
Thank you very much.